Good evening, everybody, and welcome to another meeting of the Health and Wellbeing Board here at the London Borough of Newham. This is a meeting that is broadcast live, and the broadcast will continue to be available after the meeting on our YouTube channel. You can find that by navigating onto the youtube.com site. And this meeting will be held also in person, and I have people in front of me. I'll introduce myself. I'm the Cabinet Lead for Health and Adult Social Care, Councillor Neil Wilson. I'm stepping in temporarily, awaiting a decision about the Deputy Chair of this meeting. The Mayor, Roxana Fiaz, is running late, so in order to not hold up proceedings, that is what we're doing. I hope that's clear to everybody. Is that agreeable?
Yes, Chair.
Apologies for absence, Clerk, please.
So we've had apologies from Dr. Vade, Dr. Naqvi, Councillor Mumtaz Khan, and Joe Fraser Wise, who's replaced John Root as part of a job share on the hospital.
Okay. Any other apologies, colleagues? Any other apologies?
And I think apologies from the Mayor for running late.
Yeah. I should have checked. I hope everybody can still hear me. Can you raise an ordinary hand? There's some meeting, Pauline. Can you get rid of that message? Sorry.
Oh, yes.
Is that okay? Sorry. Thanks, everybody. Declarations of interest. In accordance with the Members' Code of Conduct, the time for members to declare any disclosable pecuniary interest or non-pecuniary interest they may have in any matter being considered at this meeting, having regard to the guidance attached to the agenda. Any declaration?
No, Chair.
Thank you. Minutes are to be found, item 3. The minutes are to be found on page 11. It's sequendum. The board is asked to approve as a correct record of proceedings the minutes of the last meeting held on the 13th of July. Are they agreed?
Agreed.
I should have said before, any matters of accuracy, but there's none. No, they're agreed. Thanks very much. Any matters arising not contained anywhere else on the agenda, Pauline, that we wanted to flag up?
There's been a request to reorder the agenda.
Oh, yes, indeed. Yes. So we do. There's a request because of people's other time commitments, and it's a very busy time this time. We've been asked if we can take the item in this order. Is Simon now on the call?
No.
No. Well, let's take it in this order then. We'll take item 5 before the revised terms of reference. Is that okay, colleagues? Yeah.
Yes, Chair.
Item 4. Item 4 shouldn't take too long. Let's do it in that order. But when Simon Reid comes, if it's agreeable, we'll take the Better Care Fund recommendations higher up the agenda. Is that okay?
Yeah.
Let's be flexible. Is that all right?
Oh, yeah. And also, Chair, item 10, the domestic abuse strategy. There's no one able to present tonight, and they've asked if they can defer that item.
It was only for noting, but seriously, colleagues will have seen the paper, but it's for noting. And now entering the room is the Chief Executive. But I didn't do introductions. Very remiss. Sorry, I introduced myself. So I'm Councillor Neil Wilson. I'm the Cabinet Lead for Health and Adult Social Care. Councillor Ruiz.
Councillor Sarah Ruiz, Cabinet Lead for Children's Services.
Councillor Joshua Garfield, Cabinet Member for Education, Skills and Lifelong Learning.
Do we have any of the elected members on this online? No. So, Colin.
Colin Ansell, Interim Chief Executive for Newham Council, and also the Place-Based Partnership Lead for Newham.
And Laura?
Laura Austin Crofton, Assistant Director in the Public Health Team.
Thank you. And Jason?
Hello, Jason Strelitz, Interim Corporate Director for Adults and Health and Statutory Director of Public Health.
Do we have any other officers from our directorate? I thought I saw Simon briefly on there, but just to keep it in order, but no, we'll come back if it may be having connection problems. Charlotte, would you like to introduce yourself, please?
Yeah, thank you, Councillor Wilson. My name is Charlotte Pomeroy. I'm the Chief Participation and Place Officer for NHS North East London, and here to present item 5. Thank you.
Thank you very much. And from East London Foundation, Paul, please.
Hi, yeah, I'm Paul Calaminis, Chief Exec at ELFT.
And Marie, you're new to our committee, is that correct? And you better explain your role because it's a little bit complicated.
Thank you, Councillor Wilson. Yes, I'm Marie Truman-Abel. I'm the acting Director of Delivery for Newham, with Jo Fraser-Wise, who sends her apologies. So Jo and I are replacing John Rook on an interim basis for the next 3 to 6 months.
Thank you. I'm looking across the screen, so I'm not being hierarchical even, colleagues. Chris, please. Chris Light. She's frozen, has she?
Frozen. Sorry,
Oh,
it's my name's Liat Sana. Chris is the name of my husband, that's why it says that. I'm the medical director at Newham Hospital.
Thank you. And you're representing Newham Hospital for Simon, yes?
Simon should be also coming, but he may be stuck in traffic on his way home.
Thank you. Veronica, please.
Veronica, I was the DK Health Watch Newham manager.
And it comes up as clinical user on your screen, which sounds a bit impersonal, so you may want to be a bit more specific.
Hi, I'm Rachel Ashworth. We have met before, Neil. Nice to see you again. I work for Newham Health Collaborative as the PCN Newham Senior Manager, supporting them with transformation and development, here to give you a very brief update on their health inequalities plans that I've been supporting them with.
Thank you very much. And Julie, please, from Health Watch.
Good evening, everyone. Julie Powell from Health Watch Newham.
Ryan.
Thank you. Good evening all. I'm Ryan. I'm Ryan Suyat, Borough Transformation Lead for the Place-Based Partnership, and I'm also here for the item on the Health Equity Programme.
Right, and you're masquerading as Carl Henson, but I know you're normally a Simon Reed. Simon, you've got the wrong name up.
I have no idea how the wrong name is on my personal account. Simon Reed, I'm the Interim Director of Commissioning.
And last but not least, I can't even say that, but I know her as Addie. I don't know quite, these names are being very confusing. Addie, would you like to introduce yourself, please?
Hello, Adiola Agbe, one of two Interim Deputies Director of Public Health, and also here to speak about the Health Equity Programme.
Thank you very much. Now, item 4, we've got revised terms of reference, and following changes to the organisation clearly of the NHS, as the agenda page 2 says, the terms of reference for this board have to be changed, and what the aim is to strengthen the board's membership with improved representation. We'll still be working on that. As you can see, there are some vacancies we have listed on the attendance register on page 2. The item was discussed at the meeting of this last Health and Wellbeing Board on the 13th, was approved at full council, and there was just one amendment that I had to make, which was accepted by the council, and that was to make certain we included the right representation from cabinet leads. So cabinet lead for education, skills and lifelong learning. It was just an error on our part. And Pauline, did you say there was another term of reference thing we had to do?
Within the terms of reference, the board does nominate a deputy chair. I understand that you are to be nominated. So.
Well, it's open to the
agreeable. Maybe to note it.
Chair, if I may, I move that we nominate you as deputy chair if necessary.
Yeah, I was going to say I'd rather we went through a proper process.
Yeah.
Pauline who seconded.
Okay, right. Thank you. Shall I carry on?
Carry on to the first.
Yeah. And so the North East London ICS partnership. Shall I take that through, because we're then we're going to go to Simon. We did those two.
Chair, I thought you were going to take the better care.
Yeah, the better care. Can we do better care first? Yeah.
Well, Simon at that time was not here, so that we reordered it.
Yeah, so we will go back. Sorry, we're doing number 5, Simon, then your item. Is that okay, everybody? Yeah.
Yeah.
So Charlotte, because Charlotte's going off to another meeting. Charlotte, can you hear me all right?
Thank you.
Sorry, it's a bit complicated. So I love these 3-letter initial things, or whatever they're called, acronyms, is it, or something? So we're in the North East London integrated care system, strategic approaches to meeting Newham population need. A very important point, considering the very large population growth that we know we need to address. Over to you, Charlotte. Thank you.
Thank you very much, Councillor Wilson, and thank you very much for pointing out that we'd used an acronym in the first line of this report, which we should have expanded. So you're right, this is the North East London Integrated Care System. as we all know, we're facing huge population growth across North East London. We're one of the few ICS, integrated care system areas in the country, which is actually facing population growth. We see that as a huge opportunity, as well as a challenge for already stretched services, which we know are stretched as a result of the pandemic and also non-demographic growth and increased complexity of demands that we're seeing across all our services. We recognise that this population growth isn't isolated to Newham. We know that Barking-Dagenham is facing significant growth too, and we're aware that this will cause pressure on some of our immediate services, particularly potentially at Newham Hospital, but also across the primary care and community services as well. In light of that, we're working with partners to design a new model of care which will enable us to take the opportunity of the population growth, to collaborate with our partners, to think about work on prevention and early intervention, to work across the whole system, to develop approaches to population growth. We have presented a slide deck here, so that's by way of introduction, which really sets out our vision for Newham, which is about working with our diverse communities of all ages to maximise their health, wellbeing and independence. I think it's really important that whatever we do is focused on improving the outcomes for our local populations. Importantly, we want to support easy access to high quality services in a local neighbourhood and delivered by a workforce that is proud to work for Newham. And I know, Councillor Wilson, you've been in a number of workshops around workforce development, one of which is very much focused on how we support local residents into employment as well and make sure that they form part of our health and care workforce. By way of a backdrop to North East London, we are a large population already, a very complex landscape of over, we're in Newham are one of 7 place-based partnerships, but there are 8 local authorities, and Healthwatch I see is on this call too, 5 NHS trusts, of whom one at least is 2 are on this call. We face a number of challenges, but as I was saying, we're really keen that we don't focus just on challenges, that we take a very much a strengths-based approach, look at the assets that our communities and our organisations and agencies working across Newham and the wider North East London system bring to improving health and wellbeing outcomes. As I've already highlighted, North East London is the fastest growing place in the UK, and Newham's population growth is set to be the largest in London. Newham is already a very large borough, as you know, and we're looking at an increase in population, which will mean that all our services across all age groups and in every sphere of our activity will become more stretched. What we're proposing is that in order to address this, we look at some more detailed analysis of the model the population growth we anticipate seeing, the impact that will have on services across the system, and that we work with residents on just co-designing a new model of care with partners. We're really keen that we engage across all agencies involved in the Health and Wellbeing Board and in the place-based partnership, which Colin in this meeting chairs, to design to work together. We're starting with a round table. We've had one already, and we want to carry on that work to make sure that we can bring together all the agencies who have an impact. So that's not just the agencies that we see around the table today, but also agencies such as the London Ambulance Service, our wider voluntary and community sector. So that's the proposal. As you'll be aware, and Councillor Wilson will be aware particularly, we are doing this work in the context of developing the integrated care partnerships new strategic approach that's really focusing on 4 main priorities: from babies, children and young people, mental health and wellbeing, long-term conditions, and support social and economic development, as well as really addressing the poverty and exclusion and deprivation that a number of our residents face. So I'll leave it there. I'm happy to take any questions or comments. Thank you, councillors.
Thank you very much, Charlotte. If I refer colleagues to page 28, the future population growth, as well outlined, is an opportunity for partners and residents to get together, to work together for improved health and wellbeing outcomes. And it's not insignificant that we don't just have a roundtable event to bring together, though that's a very important first step, but also to sponsor, amongst the bullet points there, the analysis, which we can do with our knowledge of our communities, co-production, which we're well enhanced and moving along the line, design of new models of care to improve outcomes, and social care is in the concentric rings, is it what we call those? I'm trying to think on page 22. And finally, for the politicians, I think it is important that we don't lose sight of the last point, to engage with broader partners, including central government and arm's length bodies, on the resources and infrastructure required to support this scale of planning. And just as an aside, ageing well is coming up later, but we've got a very young population. But there's also going to be quite a massive increase in over 70s because people are living longer, therefore a more preventative approach. Any comments, questions? How are we going to move this forward? Colin, do you want to come in from the place space?
I had questions, Chair.
Right, do.
So I have 3 very quick questions. The first is, and thank you, Charlotte, for the report. And I know we have spoken about this at the place-based partnership. But my question is, bearing in mind the outline that Newham will have the largest population growth in London, what is the thinking currently when, we talk about the redistribution of funds into Newham, et cetera, et cetera. And so therefore, my logic says that should therefore be discussions at an ICB level, that more funding should be coming to Newham over the longer term to make sure that we can manage that growth. My second question is, are you linked in, bearing in mind some of the spatial requirements that are potentially upcoming in here in terms of some of the provision that might be required, are you linked into some of the work we're doing around our local plan refresh to make sure that the requirements that you have are considered as part of that consultation? And the third one is, in terms of that, working with residents and with partners, what are you expecting that to take? What do you expect that to be in terms of form and shape?
Thank you very much. 3 nice, easy questions for you to start off with there, Charlotte.
Thank you, Colin. So on the first one, I suppose there's 2 aspects to a response to that. The first is this is additionality, and we need to be advocating together as a system for additional funding to meet this significant population growth. There is a level of work that we can do to remodel our model of care and to think differently, to work preventatively, to work on early intervention. But with this level of population growth, I think there is something about advocating together for additional funding into the system. In terms of redistributing within North East London, our proposals, which are emerging as our financial strategy, are to think both about retaining sustainability or maintaining sustainability of our system, which is challenging given the level of demand, the complexity of the demand that we're seeing already. But the second is to use any growth opportunities, to use any additional funding that we have in to try to create greater equity in the system and to ensure that our funding is used to address one of our core outcomes, which is to achieve greater equity across the system. Recognise that is not a medium to long-term process because funding is already wrapped into existing services, but really thinking quite creatively about how we can certainly use any growth or additional funding to attempt to start that rebalancing process. On the second point about our local plan, your local plan refresh, I'm not aware of those connections. So Colin, if there are connections to be made, that would be really helpful. But colleagues who work in NHS North East London may already be linked in. And then the third about residents and partners, I think that's really about using the context that we have through the place partnership. I know that ELFT is on the call. I know do a significant amount of work to support patient, user and community leadership. So we'll be using every avenue that we can take to ensure that we've got residents involved. As an example of areas of work that are underway that will help us with this work, areas such as the implementation of the new proposals and recommendations around a reform of how primary care and urgent care are are shaped is just getting underway in North East London. So there's elements like that which will bring in resident participation too. Thanks.
Thank you, Charlotte. Thank you.
Okay, I've got in the order I've seen them and asked around the room. Anybody else on that? So far, I've got Simon. Welcome to the call. I'm glad you got through traffic. So Simon from Bart's Health place at the hospital, then Jason, then I'll take Roxanne. Is that all right? We'll take this group of three and we'll come back with any more. So Simon.
Thank you, Chair. And I'm really sorry I was slightly late joining. Charlotte, my question is really about how we're going to manage this as in the place. So I attended the first discussion we had, which I thought was a really good start, actually. And it's really great to hear we're going to have a second discussion. But it would just be helpful to hear about your thinking about how we're going to establish this as a formal programme of work and resource it appropriately as a programme of work. 'Cause it's something which needs to run over a couple of years. And I think alongside that, we also need to accelerate the integration of partners at place in order to manage the population growth. So it would just be helpful to get your thoughts around establishing this as a formal funded piece of a programme of work. And secondly, how we perhaps at ICB level help our place to accelerate integration to manage population growth.
Do you want me to come back now, Councillor Wilson, or take all these
I
questions
think
together?
that's quite an important one. I was pausing at that point because it may not all be related. So let's take that one. That was on how we're going to manage, I think, what Simon was saying, manage this in terms of the place, which is just another name, remember, for sort of borough level. We still talk in boroughs, but it's place with a formal piece of work that we're all can be signed up to. And now we might integrate greater level at place level. Yeah.
Yeah, so thank you, and thanks, Simon, for the questions. So first, that sort of programmatic approach, I think what we've set out in the report is that's the approach we think we need to take, a more structured, as you say, longer term approach that isn't about one-off meetings or round tables that we pull together the data we need. We have got examples of how we're doing that in other parts of North East London, for example, the IDF related to the Whips Cross development. So we are keen to use that as a sort of exemplar, which is about for others who may not be familiar, which is a systematic programme approach to both the strategic elements of change that are needed, but also finding routes for implementation and operationalising those, so that we manage sort of both the sort of strategic coherence and the delivery side. So yeah, we're certainly keen to make sure that we put both strands in place. In terms of integration, I think integration is underway on a number of fronts, I guess, and part of that is about the further development of the place-based partnership, which, as Councillor Wilson said, is the Newham partnership, to look at how do we integrate further, and it is through areas like this. So using the example, for example, of the integrated development framework for the Whips Cross development, it has led to much further integration on the ground between community services and local council services, between community services through a programme called Care Closer to Home, for example. So I think there are ways that we can use the programme and the models of care that we're developing to enhance the integration of partners across a sort of spectrum, I guess, from, again, including the operational and the more strategic elements.
Jason?
Thanks. Three things. So just, I mean, really echo both what Colin and Simon have said, and just on the one point that Simon mentioned about resourcing. I know you know this, Charlotte, but we currently do not have the resources in our place to do what needs to be done. And we know that work in Waltham Forest around Whips has been incredibly well resourced over a couple of years, and we are going to need that significant resourcing. So just to lodge that. The second one is, and it kind of just more part of the programmatic discussion, is I think this needs to be a standing item at the board, because we need to really, really be driving that progress. And the third was your point about advocating collectively around resources. And from your point of view, what that looks like, because if that's something that we need to be doing, then it will be helpful to from an NHS point of view, to understand what that looks like and how we as a board can really be doing what we need to do to advocate effectively for the resources, because as we know, your work sets out the future challenge, but we have a really challenged system as of today, let alone future growth. So we really need to get on that advocacy piece in a big way.
Thank you. Again, Councillor Wilson, should I take this set of questions?
Yes, I was going to say, I might segue neatly into Roxana's question.
It does. Thank you very much, Claire. So similarly, just to talk to the points that Jason Strelitz has raised, I've been looking at this document and admittedly, I'm struggling in parts. The stark reality, if you look at the big page number 25 in the report pack around Newham's population growth, and then if you look at the breakdown as it pertains to different age cohorts and how burgeoning and unsustainable the 70+ age cohort is, in the context of what you subsequently said in answer to one of Colin Ansell's question, which was maintain current sustainability within the budget that you have for North East London patch. Frankly, I just don't think it is sustainable. The second point is you talked about additionally accessing the potential funding streams that may be opening. That doesn't seem sustainable to me or viable. And I'm also alarmed at the proposed next steps element where there's the proposition that in light of Newham's significant community, civic and partner assets, these will contribute to the future health of growing population. And my reading of that is you're going to be expecting us to draw down on our own resources and sort of social assets without a corresponding proportionate injection of more resource and money in order to manage the scale of growth that is going to be happening in Newham, which if you look at the 80+ cohort, which will be placing quite extreme pressures on the acute side of the health system, that's increasing by 128% by 2041. I don't think this is a credible plan for the future over the next 20, let alone 30, 40 years. And then correspondingly, for us to be able to become a sustainable system locally in terms of a place-based approach, how will we ensure that the corresponding focus on preventative health work to mitigate against future health inequity amongst those lower age cohorts can be sustained in a credible way? One final point, if I may. Yeah. Sorry. I think the roundtable event, that's fine, but I just don't think that's going to sufficiently cut it. And I agree with Colin that this needs to be placed as a standing item for every single health and wellbeing board meeting from here on in. Mm. And I'd like to suggest that as a collaborative and as a partnership in this place, that we're much more ambitious in terms of the visioning for Newham over the next 40 years to 50 years. And also, I think there is a deeper understanding that the North East London sort of ecology needs to elevate itself to in terms of what we're doing around Newham as a place that's being driven by the local authority. I noticed there was reference to Stratford, for example, and we set here, Stratford along with Ilford, Barking and Montford will all be completely transformed with dense and high-rise residential developments, largely replacing retail. In fact, in the context of Stratford, that's not accurate. I don't know whether or not you've seen the Stratford vision, but that's not accurate.
Some responses from you, Charlotte.
Thank you. Thank you,
all of those, but
thanks.
I think that, sorry, but I'm interrupting. I think there's a consensus that we're going to have this as a standing item. So you may, want to come back for some of those really tough and I think accurate challenges from the mayor that, we need to have this as a organic piece of development in this partnership, to be open and transparent from the start, that there's a lot of pressures. So I hope that's summarising you, Mayor, accurately. So you may not be able to answer all of those, and I know you have another thing to go to.
No,
so.
well, thank you. I thank everybody for contributions. And I think absolutely right. This isn't, a round table certainly will not conclude in any way this piece of work. This is the starting point. This is making sure that we are all collaborating, drawing on the many assets we have, not to bear down on those, but to recognise that, the health and well-being of our local populations are driven by a whole range of factors which we can all work together on, which is the thinking behind this sort of whole population approach, thinking about us as a system, and that no one partner or one agency can deliver improved health and well-being alone. So really that point was just made to stress that it is a whole system approach. It does involve the whole of the NHS, the whole of local government, and we want to work very closely with the voluntary and community sector as well, for example. I think, Jason, you're absolutely right in terms of capacity and resources. These things don't happen on top of a day job. They need to be resourced properly to make sure that we have got the modelling capacity, that we do understand the impact as far as we can read them and anticipate them into the future, that we think about the impacts that this is going to have on residents' lives in a whole range of ways. In terms of your point, Mayor, in terms of sustainability, sustainability is our aim. Clearly, this population growth, I think my point to Colin was that it can't, that it can't be maintained in existing resources. We need to think differently, both about the additional population growth, but also think even within our current resources about how we do things differently to meet our current demands and complexities that we have. We recognise that this is significant population growth, and indeed at the meeting of the Integrated Care Board earlier, we took a first draft of our risk register, our board assurance framework, on which population growth was positive, because it is an area we know we need to work very differently and with partners to address over the longer term. Really keen that we work with you on that, with the full range of services and approaches from the local authority. Really keen that we work with you on your vision for Stratford and the wider Newham. This is not at this point a plan. This is our proposal, that we work together to develop the plan that will help us to meet the population growth that we're going to see and maximise the opportunities that I think exist across the system.
And if I can just make a quick comment from my position here at the moment in the chair, is that I have said, I think you've heard me say before in other meetings, Charlotte, that there's some rich data sets and information sharing protocols that we need to develop so that we could get that accurate projections. We had in the past, I'm looking at Sarah, some good data analysis in terms of birth rate projections going into Gosh's area in terms of school places. It's things like that we know information about. There are some clear pressures on particularly primary. I think that you alluded to, Colin, about how that fits in with the primary provision with GPs, community medicine, all of those services. And to reiterate what both Jason and the Mayor said, continuing pressures on the system as it is, and how we will have this as a standing item. You didn't want to come back then. So shall we let you go, Charlotte, at that point? But I'll probably see you in another meeting before the end of the week. So
I'm sure you will see me in another meeting as we work on the strategy. And certainly, if this is a standing item, which I think would be a very helpful sort of way to keep the momentum going. Thank you.
So we're being asked to engage with, obviously, the North East London footprint, some people call it, the North East London Integrated Care Board in this roundtable event to collaboratively respond as a first and a very clear, only initial first tranche go at this with the challenges presented. we sponsor a design of a program to undertake amongst other things. So, it's not an exhaustive list, but detailed analysis, which we've quite clearly, I think, come to a consensus already, we do need, with, the breakdown, as Roxana said, about the age cohorts, but also obviously in the Newham context, the rich cultural diversity, ethnicity, gender, all the other characteristics of our population. Co-production and engagement with residents, which is crucial to the Newham way of working, models of care designed to improve the outcomes and equity of outcomes. And we're talking about equity within the system on this very agenda, and the workforce and infrastructure planning that we've alluded to. Review and oversee programme plans when complete, and engage with broader partners, including the central government section and arm's length bodies on the resources, a very important thing we keep going back to, and the infrastructure required to support the scale of planning. So, may I see a show of hands on that? Is that agreed as a way forward? Yeah, thanks very much. Thanks very much. Shall I just take this one for Simon and let him go?
Just carry on.
Oh, right. You want me to carry on? Okay. Right, now there's Simon Reid, who was masquerading as somebody else in the team. But Simon, we're taking your item on the Better Care Fund.
Thanks, Chair. So for those who don't know, the Better Care Fund is a Section 75 between ourselves and health. Effectively, that's a pooled fund where the NHS and the Department of Health give the council an amount of money to protect social care and further develop integrated pathways between ourselves and health. On an annual basis, we're required to develop a plan and submit that plan for approval from the Department of Health. The plan in front of you is the one that we have submitted. Unfortunately, the Health and Wellbeing Board hasn't met in advance of the plan having to be submitted, but it's recognised that this happens quite frequently. My understanding is that the plan has been broadly approved and is waiting for ratification from the board tonight. And that's the item. Any questions?
Right. Quite a straightforward item, really. Obviously, there's some news about the Better Care Fund hopefully coming on the way for the next financial year, but this is a requirement in terms of how we have a reporting back. Simon, is that correct for what we've submitted? Yeah?
Yes, for this financial year. Yeah.
Any questions, colleagues, online or anybody in the room? No. Okay, so basically, the board is asked to approve and note the next step to approve the BCF submission. Well, that's already happened, but this was delayed because of other events, and it's gone in, but just for noting, I think, therefore. Can we just agree to note that? Yeah. Thank you. So we're back to item, we're mucking about with the agenda a bit here, but we'll hopefully people are following. We're on item 6. There's a weighty document from Healthwatch, which we welcome. It covers page 29 at sequendum, all up to 174. So who's going to introduce from Healthwatch? Is it Veronica? She looks
It will be me.
Thank you very much. Veronica from Healthwatch.
Thank you, Chair. And so just a bit about background. So we are presenting today our findings from the maternity report that we conducted across North East London. A bit of background on this report. So the maternity equity and equality framework has been revised. The North East London maternity neonatal system got together and decided to revise the current equality framework based on a few incidents that we had within North East London, particularly relating to the maternity experiences from Black and Asian mothers and young families when they were going through the maternity system. So as part of that, we worked together. As part of their work, they done a bit of co-production work where they wanted to look at the experience of giving birth for young women or women within North East London that had had a child within the last 4 years or were currently pregnant or had even lost a child. They wanted to understand the experiences of healthcare professionals who were also wanted to understand the experience of healthcare professionals who are also within the process of giving birth and how they felt about supporting these women who are giving birth at the time as well. There was a wide piece of engagement that took place from July to August of this year, within Newham, we received just over 600 responses. The analysis of this data has been looked at, and we also delivered 3 focus groups with a few women in and around the borough. Some of our findings can be found within the report, but just summarising some of our main findings from the focus group data. Many residents noted that despite the strain of COVID-19, the strain that COVID-19 had on their maternity journey, it was positive impact, in part due to the positive experience that they had with her service professionals. Some appointments had been moved online, and residents who were digitally excluded felt as though they were unable to meet and participate in those appointments. Participants who didn't have English as a first language found it difficult to participate in online Zoom sessions. And some patients noted that antenatal classes and resources that were shared with them sat behind a paywall, or they were not offered antenatal classes at all in some instances. Waiting times were also noted as issues with residents, as many noted that whilst the impact of the pandemic did inflate waiting times in many cases, this did create stress for some mothers and young families who had young mothers with young families who they had to care for. Here are some of our recommendations. We recommended that all birthing people should be offered antenatal classes that meet their needs. We understand the impact of lockdown and the challenges that it posed to the healthcare system. However, digital antenatal classes would still be useful for many residents. Furthermore, some residents who noted English wasn't their first language noted that GPs didn't necessarily offer them. And so many of our focus groups, we found that this was the first time that we were explaining to many of these residents what antenatal classes were. So with that in mind, we recommended that maternity leaflets and materials should be translated into local languages and shared in readily available maternity settings. Upskilling staff on bedside manner to ensure that residents do not have negative experiences when accessing services. And finally, we recommended that improvements to waiting times for mothers in hospitals, such as, healthcare professionals engaging with these mothers and ensuring that they're kept aware of how much time they anticipate they would need to wait, particularly if they have younger families. That was the analysis of our focus group data. We're doing a massive deep dive into the analysis of our local data, and the report of which will be submitted in upcoming health and wellbeing boards. The NEL-wide Health Watch work has been used to filter into the wider maternity strategy, of course, across North East London. And it's my understanding that local maternity services are being given localized plans. However, the Health Watch engagement part of the work, which forms part of that strategy, and our local engagement analysis of that is coming out. Are there any questions?
Right, thank you very much. Thanks for that. I note, and I think it's within the context, and thanks very much for the work from Health Watch on this, that on page 33, that there are approximately 550 new births every month, the highest proportion of newborns in the North East London area. And obviously with the ethnic composition of the presenting mothers, both at hospital, but in prenatal and antenatal care, and the very important issues raised, it is a feature of a discussion that I know that we're all very keen to get right. Scrutiny is also, as you know, is having a long-term look at this in terms of the health scrutiny. And there's also an event today that we may want to allude to that some of us were at in terms of some of the issues raised. Enough from me, over to comments and questions. It's more possibly not so much questions, Veronica, about, comments as well on this. Sarah, would you like to start?
Yeah, I would like to start. So thank you very much, as always, Health Watch, for a really useful report, and I look forward to the report coming. Sorry, I'm looking this way. Of course, you're up here. It was just really a suggestion on the second recommendation, which talks about maternity leaflets and materials should be translated into local languages and shared readily available, and should be readily available in maternity settings. I'd really like you to put GPs in there.
Okay.
Because the very fact that you mentioned maternity settings assumes that the woman has actually got that far. And many are only like they get to the GP and that's where the issues start. So, but I also note that there has been significant improvement in maternity provision at Newham University Hospital.
And as if by magic, Simon has put his hand up. I think you wanted to come in on this, Simon.
Thank you, Chair. Veronica and I have met before through scrutiny, and I just wanted to compliment Veronica on this piece of work. It's a really fantastic piece of work. And Veronica, as a hospital, we're really keen to continue to work with you in partnership on this and regularly take your feedback about how we can improve birthing people's experiences at the hospital and at Barking Birth Centre as well. So if you're not already adequately in touch with our team at the hospital, please drop me a line and I'll make sure you're well connected with our leadership team in maternity. But a really great piece of work. Thank you, Veronica.
Thank you so much, Simon. And just to note that I do believe that when we deep dive into the Newham data, we will be working very closely together as well.
Simon, just for the benefit of minutes and everybody's understanding, can you just briefly explain the Barking reference? The Barking birthing reference. I know, but I think it's important that we share what that development is about.
Yeah, so Newham University Hospital provides both antenatal, intrapartum, so birth care, and postnatal care at the hospital. There's also a low-risk midwifery-led birthing unit on the Barking Hospital site, the community site in Barking. And Newham University Hospital also provides that service on in the Barking footprint, and we provide antenatal, postnatal, and low-risk midwife delivery birth care at that unit. The activity at that unit's quite low, so there is just a question about the sustainability of intrapartum care at that unit, which we're looking at to make sure we get right. But there is no question about antenatal and postnatal care at that unit, which is really important to local residents. So we essentially run those two centres, and Veronica's work around birthing people's experiences is really important in our continued improvement work around those two areas.
Thank you. Jason. You're on mute, as we all.
So I had one comment, and then Simon, I just actually had a question based on what you just said. So the comment to Veronica was just thanks very much, and I think it's really interesting having this item before the next item, which Adiola is leading on the equity programme, because I think it's such a powerful example of the kind of deep dives that we need to do across all manner of areas to really understand the equity challenges and what we need to do to address them better. So I just wanted to say that. And then it was a question that what you said about the sustainability of the birthing centre, and is that about patient choice, or is that about the level of risk that we have in pregnancy in the community that means there's smaller numbers of births going through that centre?
Yeah, I think there's a number of factors. One is about birthing people's choice. The second is risk. You're quite right. A lot of our birthing people are quite high risk or have needs which require birth to be at the main hospital site. And there's also the midwifery staffing challenges that we face nationally. And when we have shift shortages at the hospital, we pull our midwives from the low risk unit to support the higher risk unit at the hospital. So that we do intermittently have to shut the low risk unit on occasion to bolster the main hospital. Now that often sticks out a bit more because we're running to geographically remote sites where in the vast majority of centres in London, the low risk delivery unit is actually co-located with the main hospital, and the Barking Birth Centre is one of only 3 units in London which is geographically remote to the main hospital site. So There's a kind of number of things to think through, as you've alluded to, but also we need to link it to the issue we have around workforce supply nationally around midwifery.
Thanks.
Any other comments on this? No? But I think Jason's right. I mean, if you look at page 204 about what an organisation can do to address health inequity, I don't want to take anything from Adeola's contribution later on, but it does mention there about the good work that we're hopefully talking about next in terms of training, unconscious bias training, and one of the contributions from people who using the services over the years has always been that people need to be listened to, but heard and acted on. And, it needs to be an open dialogue so that people, particularly the cohort we were looking at this morning in terms of really, vulnerable women who've come, as refugees, asylum seekers, there's a language problem and it's about how we can listen to those voices who are not often heard, or communities that are not accessing or using your service, but how we may, really tackle that. Veronica or Julie, anything you'll be coming back with the next phase? I could miss that.
Yes, we'll be coming back with the next phase, and some good news earlier today. So we've been recommissioned to further deep dive across the work in North East London. So Health Watchers across North East London, there's more work to do as well as a local deep dive. So this is going to be a top priority for us for the next year at least. Thanks very much. Shall we? We have to agree to the recommendations when we note, because it's your work. We're asked to note the findings. Yeah. So is that agreed, everybody? We are noting? Yeah. Thanks very much for your time and help on this. Thank you. Now, the next one. I think it's Adeola, isn't it? We're moving into. So I invite Adeola to introduce a report to be followed by any questions. So Adeola, over to you. Health equity.
Thank you very much, Chair. And thank you for the people who are online who have also joined for this. This is a piece that was deferred from earlier in the year, and we wanted to just add some more updates to it. With the Chair's permission, I'd like to be able to share an updated slide pack.
Yep.
Thank you.
Have you sent it to the clerk?
But if you send it to me, I can do it.
Okay.
I'm glad we got Pauline on this because of technology.
Directly.
You're going to share them anyway, aren't you, on the screen?
Will I share it directly and then I'll send it?
Yes, you can. Yes, you've got sharing.
Oh, it's crashing. Great. So the health equity programme, as you have seen from the material that's part of the pack, is a system for exploration and learning around how to address and mitigate health equities in Newham, with the focus being on learning and sharing that learning in the system so that we can all pool our knowledge and share the learning widely and create and share good practice. There is also, as part of within this, if you've got your first slide sets out the case for change. The second slide sets out what we could call a theory of change, which is that by committing to this work and doing good work, we will collectively have learning, and that learning is twinned with action. It's not just learning in the abstract, it's learning plus action. So the two key parts that have been set up during the formation of this programme are a system of learning, a community of learning, a programme oversight board, and some tools to support that learning. So if we just move to, this is the theory of change, the continuous cycles of learning improvement, which are linked to what in the NHS, our partners ELFT and BARTS have a quality improvement methodology, which is a test and learn improvement cycle or a change cycle. There are lots of different ways of approaching this. Some of the language is very formalized and codified. And within the borough, we have one exemplar award-winning unit in ELFT who are supporting this program specifically. And we also have colleagues in BARTS who are supporting indirectly in other ways. So essentially, do some good work, do some learning, share that learning, pool the learning and start to create across the health and care partnership what is effectively a toolkit, a way of approaching health equity in Newham with its unique challenges. This is an updated governance diagram. It's color coded for ease. The green layer are the accountability responsibility layer, which shows this board, the Health and Wellbeing Partnership, the Health and Care Partnership Board, and each organisation that signs up to the route map and that joins the programme is responsible for its own pathways and its own output. Blue groups are the groups that they happen monthly and alternate months. Leadership group or programme board, which contains leaders at various parts of their organisation who are able to drive change, advocate for change, lead change, and the learning community, which is open to anyone to learn and share and attend. And so these happen in alternating months. The purple work streams are the work streams that will come next. We have the primary care variation reduction group and diverse communities are up and running. The others are enabler work streams. They're work streams that support the rest of the work. Recommendations around policy and practice, or with distilling, learning and toolkit type like activity. And the orange work stream, so tonight we're going to have some examples and partners to share from the orange work stream and the primary care variation work stream. So we have a bit of funding from the NHS to support around improving equity, some quality improvement support, which is there to be able to train people in pocket QI, which is a cut down version of the ELF QI methodology, and also to support groups of people deep diving in a similar area. We have got a group of about 6 people working around the diabetes pathway, and we're hoping that one of our partners will also attract some people to work around that. And then in time, I'm sure we'll be able to think about some people to support Veronica around those maternity pathways. As part of our setup, we were asked by the first programme group and the workshops that formed this to concentrate on all pathways. So not just the service in isolation. It needs to be set, but whole pathways. And for us to do that, we need to group up different QI projects into these more focused learning communities within the wider learning community. QI often works best if it's focused and narrow, but the learning works best if it can be shared and the generalizations and things that are applicable can be linked across different pockets of learning. The other thing that we have from our setup is this, effectively, it's a maturity matrix, but we call it the Newham Health Equity Route Map. There are 3 levels as applying to an organisation, which is the entry level. You sign up, you buy, and you have commitments. That applies to a service or a team, which we're again in discussion about how starting within the council, but also thinking about other organisations, how that's then applied to teams so teams can adopt it and use it to direct their QI activity. In around about 6 to 9 months through the process, we anticipate we will revise it and Newhamize it so that it say, in order to look at domains 3 and 4 within your pathway, please do some QI work. You can get QI support from these partners and these partners. And the more we do this, the better we'll become at it. This is an update snapshot of the number of anchor organisations that have so far signed up to the route map, or those that are in process waiting to have it presented to their governance boards. So we've just got a couple to go, and we also have input and support from the University of East London as well. They're working out how they want to engage with this. This is just a short pack of programme highlights, which I'll send around for you to read at your leisure. And this is an addition to the pack that you already have. This is just a summary of the activity that's happened so far, which I won't do in detail, but we have got a community around this work that are interested and motivated, and we're doing our best to keep them interested and motivated by giving varied content for them to engage with. And this is our Improving Equity Programme, or Deep Dive Orange work stream, and this is the in route map form the key projects that are up and running that act as a node or a kernel for other groups to come and coalesce around them, working on similar parts of their linked pathways. So I'd now like to ask colleagues to and share their projects. We have 3 colleagues from the health and care system.
Just before you do that, sorry to interrupt, Daddy, can we go back to that map? And I think it would be helpful just to pause there before we bring the exemplars in, if that's all right with you. The road.
Oh, the road, yep, total.
The road. I know I've seen this slide before. I don't know what else to call it really, the road. And it's we're not going to go through each one tonight, are we? But, you know, I think that slide is helpful because it draws the point, I think, that we were in a previous discussion earlier on at an event about immigrant and asylum seekers. The very crucial thing about dental health that's had some quite damning reports, particularly in the Newham context, about availability of dentists, let alone, you know, the state of dentistry, not least in the 0 to 5, if I remember my figures correct. And diabetes, young black men, we've had a whole series of issues around black men overrepresented in mental health services, and the Safeguarding Adults Board, which is a quite important topic. My question, if I can abuse the chair, is you do seem to need to reach out to the voluntary community and faith sector, because if the COVID pandemic has taught us, they may be closer to some of the communities in terms of equity. So, yeah.
Yes, that's definitely true. The voluntary community and faith sector are an integral part of our thinking around this. There is a model that has been emerging of how we think we need to develop capacity and work with that sector that we were developing during COVID and during 2021 with a different project called Healthy Communities Together. And Jason, myself, some of the programme board and our colleague Anne Bowers, who is our community lead, are working on thinking about how we describe that and how we work better with our community organisations. In Newham, the landscape for the VCFS is quite different from a lot of other boroughs, that we have a really vibrant landscape, but very often small, often under-resourced, often not able to take part in strategic work. So there's a piece of work that's funded by this branch of London Inequalities money, which is looking at work differently with communities. There's a piece around participatory budgeting. There's also some broader system thinking about how we can develop and build capacity in that sector, capacity and also sustainable capacity building, which is an ongoing public health and adults and health project area.
Any questions or observations for people in the room? Sarah?
No, just I'm interested in the in your very perceptive view of the voluntary community and faith sector, who would be absolutely willing to participate if they were able to. And I think that it's maybe some work that needs to be done, maybe through compost, to perhaps skill them a bit or give them a bit of support. So, but I think that without them, it won't be as rich. And I'm assuming that we would be looking to work with schools as well, or not?
So this particular programme is really quite closely focused on the main client group in this programme are statutory services.
Okay.
But we also understand that part of the model, if we think about it at population level, part of the model is to be able to support statutory services to understand better the lived experience of their future clients, but also to support residents to be able to access statutory services. And there's a definite role for the voluntary community and faith sector in that bridge, and how we're still thinking how we work best with them and what that looks like. Schools as another setting as part of the Health and Wellbeing Board strategy, the 50 steps, another really important setting. And there was the launch of the Healthy Schools programme just last week. So that's something that will come into play, but isn't a direct, immediate and direct. If something comes in where that schools are a part of that, then absolutely. It's not. So the purpose of the programme is to create the arena in which we can do learning and sharing. And then once we start to do that more and understand how to do it well, we will be working with open to working and sharing with different partners. So no one is excluded from it as a kind of work stream. This is where we started in that health and care space.
Thank you.
I've got Roxana. Anybody on the screen, Pauline, who wishes to come in?
Oh, I've not.
It's a bit difficult when you're turning your head and you got to just. It's my fault for asking for the road.
There's no electronic hand.
Okay, Mayor.
Thank you very much. I really welcome this report and well done to you and everyone else that's been involved in developing it. Just a couple of quick questions. Firstly, in terms of the ART-S framework, is it subject to an ongoing process of finessing and improving, as with any R&D proposition? I appreciate a lot of the framework has been brought from the experience of COVID-19 and vaccine take-up particularly, but the different iterations of our COVID-19 experience and journey. So that was one question. The second was, how do you future-proof this? And I guess actually it's linked to the ongoing evolution of this and the R&D approach to the framework. How do you future-proof it in light of the data that's pointing to, burgeoning numbers of sections of our community from different age cohorts? There was the publication of ONS data, latest release, that showed or highlighted actually English is a minority language now spoken in this borough. So just wanted to get a sense of how those facts and those realities are being built into the framework.
That's a good question. So, and thank you for picking that out, Mayor. The ART framework is definitely a central part of this. So, the first thing is there is an iteration in the framework itself and also how we use it. We've dropped the S for the time being. That the S is now sort of somewhere between R and T. Because art is just nicer to say than art or arts or ART-S. So accessibility, relevance and trust. You're quite right. It's a reworking of a WHO 2014 SAGE framework around vaccine hesitancy. And we changed the words because the original words, while WHO like a framework that's got one letter, and that has a great power for translation. But the words, when translated into English, were slightly othering, so that if you talk about complacency, it doesn't really feel terribly inclusive and putting yourself in the shoes of the person you're trying to attract to your service. So we find that accessibility, relevance and trust works better, is more inclusive and supports services to think more about the things they need to do to attract people to come into their services in a way that isn't starting with a narrative about why the people are wrong not to come. Within that, we're still learning how to work with it, how to code against it, how to make it really usable. It is very open, and an open coding system has got both strengths and weaknesses, and one of which is where you place shame and stigma, which has got a slightly different resonance. But we're going to continue to work with it. It has the beauty of simplicity. It is pretty robust. When we created it, based on the back of a vaccine framework, we were thinking about other prevention services and that observing whether people do or don't go was too far, and bringing other evidence to bear that it's at the wrong time. The appointment's at the wrong time of day. The invitation letter was in the wrong language. The invitation was in the form of a letter, not an SMS. There's learning in the borough about sending an SMS to the bottom as part of the Core 20+5 work. From college, the South 1 PCN, they found that people didn't respond to their SMS messages because they can't read, so that they called them instead. So there's a lot of this learning that's rich, and that's not going to need future-proofing. That is still going to be true of Newham. It's still going to be true of it's going to be true of a proportion of Newham. Okay, some of that will be true, and some of it we can start to create pathways. If the issue is people can't read, then we have more literacy classes. If the issue people can't read English, we have more language classes. So we get to a point where then it isn't as true as it is now. So yes, you're quite right now. But it doesn't, the core processes, the core way of thinking about this are pretty evergreen. And it's within that quality improvement approach. It's within the art approach, like describe what you can see so you can understand it and share the understanding, share the learning, and then look at your pathway in a systematic way so that you understand where the issues are. And those processes are pretty robust.
Quick follow-up question. I'm really excited by this, and thank you very much for your response. And what happens if, so I appreciate it's a learning programme for practitioners primarily, and what happens if they don't, if over a period of time, what period of time will that be? If they're not shifting sufficiently in terms of their practice, because they're going to be holding us back in terms of the equity in health lift that we want to see across all those different cohorts of our community, and we'll have a prioritisation as well. So is there, what's the penalty, as it were, for, even though that's contradictory to the ethos of this, but...
So, so the governance structure and the route map are there to keep the action moving forward and on track. And again, you're right that it's a system without punishment. It's about learning, because people would otherwise be defensive. But there are, if you look at the route map, there are aspects about accountability in systems, there are aspects about workforce, and it's building those in, Newhamizing them over time. So we're using more Newham type language and resources in that framework, in that route map. But the route map is there for people to make use of their learning and to keep people on track. So that we'll have some sharing later, but organisations that are doing a benchmarking process against it to see where they are. That means they can come back in a period of time, having done some of this deep dive exemplar work, having done some thinking about their own systems and processes, to be able to see if they've moved. Hopefully they will have moved, and that we should see a trajectory of movement against that. In addition, we also need to think about how we think about outcomes, and one of the enabler groups is looking at data and insight and evaluation and outcomes, how we embed good practice about counting things regularly. Do we have a minimum equity data set? Do we all agree to the same one, or how we think about evaluating the program itself, but also individual service pathway outcomes if they've made a change. So all of that needs to be in process. It's a lot of plates to spin. But if we start with what is effectively the move towards a culture change, and move towards getting people to be curious about this in their service pathways. I see Jason's hand.
Well, yeah.
If I may, just one final question, Chair.
Yeah.
It's true. It's really heartening. And just wanted to suggest for two things really. One, that as members of the Health and Wellbeing Board, we actually go through the programme and learn ourselves. And secondly, as a political organisation and entity in this space and the wider health ecosystem in Newham, obviously the council, whether or not we can look at how this is then socialised as a training package for all members of staff, and perhaps starting off with, senior leadership. But I think this is important because we're not going to be able to accelerate the health equity that we want to see in the time that we need to do it.
We could lead by example on all of those messages. Jason, you wish to come in, and then we'll go to the examples, because
Thank you.
I think we'll clarify some of the issues that we're already sort of grappling with. So, Jason.
Yeah, no, I mean, really, I think, Roxana, your questions and your suggestions are really, really right, and really welcome them. And I think it's about us as leaders here. It's about, myself, Simon, Paul, Tim, and how we, Marie, how we drive this through our bits of the system, and taking that responsibility and that accountability to make sure that this is progressing. But I'm so supportive of this. I think it's a really thoughtful, grown up, honest, realistic approach to trying to address these long-standing complex issues. So, yeah.
And we say we're going to move to the examples, but I've got one point, and then I think Sarah wants to come in. Is that all right?
Very, very quick.
Yeah, you come in and then, yeah.
I think if we're, I welcome the fact that the suggestion of Health and Wellbeing Board members going through this, but actually I think it would be really useful to have a presentation at one of our regular CAF meetings.
Yeah.
Once we put the budget to bed, perhaps, March.
Member briefing.
Yeah, but I think it needs to start.
Yeah.
The executive.
There are different audiences, aren't there, really?
Yeah.
And we need to understand it before all members, because if they ask us questions, we need to be able to answer.
Mine was a fairly quick one. I mean, Roxana mentioned the ONS data. I mean, on page 201, yeah, I agree, ONS data, but demographics and, statistics and all that. ONS data should be used at fairly obvious, and Roxana's alluded to languages spoken within the borough, but English is a minority. We've got fast changing collection of data. I keep banging on about how we could data share more and all the rest of it. That's part of the learning. But then if we get really advanced, it'll be collected data can be accessed and used at all levels across the service for analysis, while conforming obviously to GDPR and the protection of confidentiality and all those issues. Removing identifiers where necessary so team members can access data for purposes of informing health equity. Because unless we get that right, we are making some of the same mistakes. And we still have the overrepresentation of black men going into mental health and then into the criminal justice system, or other issues. Sorry, you've got some project leads.
By a direct segue, Rachel Glover, would you like to come and just briefly the clinical talk to your project?
Yeah, sure thing. Good evening, everybody. Lovely to meet you all and join you stay at your meeting. So my name is Rachel, as mentioned by Adiola. So I'm a therapist at Newham Talking Therapies, but also the lead on the quality improvement project at the service. So just to give you a bit of insight in terms of what the project is looking at. So the framework, as mentioned by Adiola already, is the quality improvement framework. And the purpose of the framework is to give a systematic process to solving complex problems through testing, but also learning. And how we started this project was following doing a service audit, and the service audit was in accordance to the British Psychological Society positive practice guidelines in terms of how we can best kind of structure the service, but also if the service is actually doing what it needs to serve people within the BAME community. From that, we got data, and one of the sections looks at how people from the Black demographic, all the demographics were actually being represented within the service in terms of referrals, completion of treatment, as well as re-referrals as well. And the key point that was brought out from the data that there was an underrepresentation of Black males between the age of 18 to 25. Following that, we followed up with senior management as we identified that there was that discrepancy in terms of the underrepresentation. As we can see on the framework, understanding the problem was a key part of that. And I guess that is quite a large concept. And in order for us to do that, it was important to get an understanding of what's actually happening by reaching out to stakeholders. The stakeholders included therapists within our service, service users within the community, just anybody that would give us this information. So we reached out to faith sectors. We also reached out to community leads, as well as community organizations. Following receiving the outcome of that, we analyze that data, and that will come back to that ART framework, which Ajay's already mentioned. And where we're at right now is the implementation of some of the change ideas we received following the questionnaires, but also the collaboration we've been having with stakeholders within the service. So if we move on to the next slide. As mentioned, the project is looking at increasing representation of Black males between the age of 18 to 25, as we could see that the demographic made up 18% of the borough, but were significantly underrepresented within the service in terms of referrals. And as already has been alluded to, Black males do make up more of secondary services and are more likely to be sectioned, but also receive more compulsory treatment, which highlights there's a difficulty there as we are a primary service. And hopefully if we are able to support people from the inception, they're less likely to then go on to secondary services or get understanding of the process before having more intensive treatment. So the QI framework allowed us to go through that process. Next slide. The key learnings from the project so far, it's only been about 11 months or so, is that it isn't a quick or simple process. It's not a linear process. The timeline looked quite simple, but it's not been like that. We've gone from change ideas to understand the problem more, reaching out to stakeholders. It's not been a steady one either. But I think what's been really helpful is the fact that stakeholders are involved in this project, that the investment of time, energy, resources have meant that people have really bought into the concept, but also want to see that change. And the fact that the research or the project has come from data means that we can then evaluate it as we go on in terms of months if there is changes in that number. The project has also highlighted that co-production is imperative within treatment and within the projects, as we can identify that we can't make changes within the service if the people that we're trying to support aren't represented in the change. But this has also been an area that we've had some difficulty with, actually, in terms of getting service users that actually want to be involved in the project. But we have been able to get research as well as support through the questionnaires, for example, but more kind of consistent support or representation within the project, something that we've continually been working towards and continue to work towards as well. I see that key strengths of the project that we've been working on is the fact we've been actually able to learn from other organisations as well, and other projects that have already been run. And that's a key premise of the equity programme, which is the idea of actually being able to have that shared learning. So Adiola was quite great in terms of leading us in terms of the research that's already been done in terms of the COVID up. Oh, was someone sharing something?
No, it's all good.
No, so in terms of the COVID uptake, in terms of vaccines, and the ART framework was something that was really helpful when it came to data analysis. So in terms of accessibility, relevance, and trust, that was a means of us actually being able to analyze data using those key titles. There's also been a project run by Samuel, who's the lead people participation lead, who highlighted from the Let's Talk programme that this is a difficulty that they've identified, and key difficulties that were raised in the report were language and use of words such as hard to reach groups or barriers. So that's something we've definitely taken into consideration as we continue with the project. Other key strengths that come from the project is actually the support from the Trust. The Trust run an Improving Leaders programme, which I've been able to be a part of, as I am a clinician by background. So actually being able to get support in terms of leading the project has been very, very helpful. And yeah, just being able to reach out to others beyond our service. So apart from us being clinicians that work with a varied demographic, actually being able to reach out to community organisations who have that hindsight as well as that insight as they have that integration on a day-to-day basis. So that's just a little bit about what we're running the project. I know my colleague, Deputy Lead actually, Chris Spanton, has spoken to you previously, so I'm looking forward to coming back once we've gone further in the project in terms of implementing our change ideas to inform you of the follow-ups.
Thank you very much, Rachel. And I'm sure it was Samuel who came about the Let's Talk project to scrutiny, and and it shows that we're quite joined up across the piece in the authority on this. And speaking as an ex-governor of ELF, the quality improvement programme is the right framework for this, because if we've got underrepresentation at talking therapist level, it's not surprising we have overrepresentation at the more serious end, of the mental health provision that may be inappropriate, non-targeted, reinforcing a whole load of stigmas and all sorts of things. But great example, Rachel says. I hope you're seeing the chat in there, Rachel. So thank you very much.
Thank you
for the good work. And you'll come back as you promised.
I shall. Thank you very much.
Thank you. And the next one,
it's an update from Ryan Suyat on one section of the beginnings of the diabetes pathway review. So this is the start of what is going to be hopefully a group of about 6 people learning on different parts of them.
Focusing on type 2 diabetes, yeah.
Thank you, Chair. Thanks, Adiola. And yeah, as you say, this one's around diabetes, but before I get into that, and I'll be brief because I'm wary of time, it's great to hear from Rachel just now about the progress that they've been making in terms of their project. And I think that's kind of what this health equity program is all about, in terms of learning from others as they go through their kind of project cycles and their quality improvement cycles. So so this project is around type 2 diabetes, and it kind of builds on from the work of earlier this year that the public health team did around identifying what we need to do to support and to improve outcomes for our population. So what we did is we convened a workshop, a face-to-face workshop with stakeholders from across all of the organisations across the borough, including a couple of residents, to get them in a room, which was quite nice, and just get that kind of soft intelligence to begin with in terms of what they feel are the challenges what works well, what doesn't work well, and do people even know what the pathway is that we are working to. So we explored that, and then we kind of moved on to what were the opportunities, and we've got them there on some of the kind of feedback on the page there. And a lot of it was around co-production, which we've talked about a lot at this meeting, which is great to hear in terms of we want to make the residents' priorities our priorities. So that's where we definitely need to start. And then some kind of more specific things around uptake with structured education or uptake and access or outcomes for specific cohorts of our population. The only other thing I'd mention on this page is around comms, and I think that's a real key enabler for us in terms of the diabetes pathway, and probably wider than diabetes and wider than this pathway work in terms of sharing information, not just with our residents, but also with our staff and our workforce, so that everyone's aware of what is available, what we've got in terms of provision, and we're just working as efficient as possible. Next slide, please, Adiola. And just a couple more of the opportunities that came out throughout the day. We've got in there around inequities. We know the borough is very culturally diverse, and working with the health equity programme and working with our leads across data, which we've also mentioned in this meeting, to kind of unpick why certain people aren't accessing services, why certain cohorts of the population aren't achieving the best outcomes that we would hope them to. And then the last slide, to wrap it up, just kind of touches on the priorities that we want to take forward. So as we said at the beginning, this is the initial step. What we want to do is kind of develop these further with stakeholders and with the voluntary sector. We're keen to engage with them. And start to look at each of those areas. I think Adiola mentioned it, that there's probably 5 or 6 people that will be able to support on this program and take individual kind of aspects of the program to look at and do a bit of quality improvement on, which is great. So we can start kind of testing new ideas and iterating them as we go on. But yeah, start of the journey, and hopefully we'll be able to come back with some progress at some point.
Thank you very much, Ryan. If I can just come in, I put this additional slide in, just looking at that we've got about 4 pots of potential activity around diabetes prevention, and this review is looking at secondary prevention, which in itself is a complicated system. We're also looking at groups and exemplar projects that are at different stages of development. So Rachel said she's been working on her project for some time. This is a group where they're just beginning to go on that improving equity QI leaders work program, which runs till March. We also have, and we'll come next to Rachel, who's also on that program, and Rachel from Docklands PCN will be supporting primary care colleagues and primary care projects around their QI projects with Fiona Lord, who couldn't be with us tonight, who is the other improvement advisor that's supporting the program with training and support.
So do you want to bring Rachel in? Because I was just going to mention that, what's very interesting here, I think, is not just the structured education and the reference Ryan made to working with voluntary and community faith groups to increase that outreach in terms of, like we're learning on the COVID example, that we do need to get maximization of people, because our type 2 diabetes profile is certainly very worrying. But I was interested with the community pharmacy point of view, because if we've got a genuine commitment to reach people where they go, in their high street, and this, whole idea of 15-minute neighborhoods, or the development of accessibility to services, both physically as well as, geographically, and non-barrier and judgmental. So is that where we segue into Rachel's work?
Yes, I think so. Rachel Ashwell, I'll take the slides down.
If I introduce you correctly there, Rachel, do you want to reintroduce yourself? Because you're down as a clinical user.
I know. So I was just looking to see if I could find my slides. So I did actually send the slides, but
sorry, my bad. If I didn't append them, let me see if I can look at them and add them in.
That's okay. I'll just I'll go ahead anyway. So basically, I was working as a PCN manager for Docklands Primary Care Network for the last 18 months, and in June time, primary care networks were, as part of their contract, so as the contract that they deliver services to, were asked to develop a health inequality plan based on their local population health data and their population health needs. So Newham decided that what they wanted to do is come together as clinical directors and to share that learning and to work together to make sure that services were delivered across and that the plan that they were offering would be impactful for the whole borough. So they decided that they wanted to focus on cancer and immunisation. So cancer at the moment is for all age groups, but with a focus on the BAME community, and the immunisation is also all age groups, but a focus on parents of young children. So with that programme, the immunisation side of that has been already sort of moving along, and Helen Page has been managing the roving team to do a lot of that work, and it's going really well. But with the cancer one, at the moment, I think what we need to do, we have got a draft implementation plan, but the QI project has given me an opportunity to say, let me look at the cancer side of things and see if I can sort of reinvigorate that side of the work and take that back to the primary care network director. So that's what I'm hoping to do as my role in QI. We've also, as well as that project across the whole of Newham, there is a number of PCNs, I think it's 5 PCNs that also decided that they wanted to do individual projects. And I'm pleased to know, Neil, that one of them is the migrant communities that are at the moment temporarily in our hotels in Dockside and Ibis Hotel for Docklands. And that work has really motored along thanks to Public Health and Lizzie and Laura for their support in helping to facilitate meetings with the people who manage those hotels. And we've done some really fantastic work with Public Health already around sort of looking at what the needs are of that community. And it touches on what you said earlier, Neil, around young mothers and people who are pregnant with young babies feeling quite unsupported and uncared for in that kind of accommodation. So we're sort of picking that up. We've also picked up on the dental health side of things. So as you'll see, one of the projects that North East 2 are looking to deliver and have started already delivering is access to dental health information and services. And through that, we have also identified that not only do we need to be giving out more information to patients within that PCN and across PCNs, but also we've had some what's called dental health kits provided to that PCN, which we're also going to provide to the communities that are in those hotels currently. So that's really good news already. And then you'll see we've also got in North Newham, they've got food poverty, which they've linked to weight management and diabetes. And that was on the back of the work they did during COVID with the food banks. They want to share with other PCNs, which is what this is all about, their work that they've been doing on the proactive care clinics around long-term conditions, and they've taken that work forward. They're sharing learning on some COVAX work that they did and the model that they used. And then going back to Docklands, we've also got two PCNs, Docklands and South One Newham, who are looking at SMI, and both on weight management and diabetes, but one is also focusing on a particular medication, clozapine, and how that is, whether that's been prescribed long-term when there's not the need to do that. So there's a bit of work going on there. There's been some audits done there. I'm almost finished, sorry. And then the last one is learning disability patients to improve access to LD health checks and wider primary care services. And that's not just saying, let's look at LD health checks and increasing the number delivered. That's looking at perhaps those group within that cohort who don't engage with the LD health check. So if they're not engaged with that, what else are they not engaged with? So I think that's in a nutshell. I was told to be really quick. So I'm happy to provide any other information, come back again, whatever. So thank you for inviting me.
Very, very helpful. There's a variety there. If I captured some of it in terms of both targeted to BAME communities, immunisation of young children, the work within hotels, the very complex issues of, asylum seeking, non-recourse to public funds, all those issues, dental health, food poverty, weight management, and learning disability patients, so making certain that they are included. And well done. I'm glad. Jason, was that a question on those specifics or a statement? Yeah, you want to come in now? Yep.
Yeah, just a quick question, Rachel. Really, really loads of fantastically impressive work. Very varied. So what's the process for capturing the learning and scaling the learning across across the PCNs from these different pieces of work.
Nicely PCN, I think.
No, me too.
Oh.
So right. So one of the ways in which we're doing that, hopefully, is through me participating in the QI programme, and also promoting the pocket QI with primary care that Addy mentioned at the beginning. But it's also going to be through the clinical directors meetings, sharing on hopefully PCN websites eventually, and on the NHC website, and with partners. I think the more that we share what's happening, the better. Just one other thing that I wanted to mention, this first piece of work, these projects were all done as part of the DES contract, and but it's fair to say the clinical directors did kind of sort of look at it and say, I'm not really sure, you know, why do we do this? How do we lead on this? But just recently, in the DES contract as well, they've been asked to look at how they might provide social prescribing proactively, so finding people rather than people coming to them. And we've had fantastic response from all of the PCNs with really good ideas, and they include, you'll be pleased to know, Sarah, I think you mentioned around children. One of them's around knife crime, and the other one's around children and young people and mental health. So that's coming from PCN. So I think that we've already moved on massively. So it's great. It's all good.
Yes.
Yeah, very good.
Sounds amazing.
Excellent. Yeah. And it's a variety, capturing all of those issues, which have all got an equality dimension to them, you know, about young people who may be not only excluded from school systems, but also wider family network support, not registered at GPs or, you know, whatever, all of those issues. Eddie, have we finished on the presentation?
Yes, thank you very much.
That's been remarkably rich, I think. And thanks very much to all our partners on that. And I certainly would like, I hope I'm speaking for other members of the board, this to be, we keep saying an update because we had one, you know, we missed one. So we're doing catch up in a way, aren't we, Adiola, with this? So what we're asked to do is to basically turn to the recommendations on 176. Hope I've got my page right there, Pauline, haven't I? Yeah. To make a commitment to oversight of the delivery of health equity, which we certainly, I think, would all concur, to adopt the Newham Health Equity route map, and to champion recommendations from the programme for stakeholders and board members as they arise and are shared with the board. So it's going to be a standing item in a sense, which item recommendation C does. Is that agreed, everybody?
Agreed.
I think we have to show hands.
Never shown hands here before.
Well, it says on this script here.
Show hands.
I think that'd be one of the show hands.
Should we do jazz hands?
Thanks very much, everybody. And if you need to go, go. But otherwise, you're welcome to stay.
Yeah.
And the next item, as we got this because we got out of order a bit. It's the SEND improvement update. And have we got Jessica to introduce? Hi, Jessica.
Hi there. Good evening.
You want to introduce?
I was hoping
She's got a 20-minute.
Oh, you haven't got 20 minutes.
Oh no, not at all, Sarah.
Sorry, Jessica. Lead wants to introduce Joshua.
As opposed to being mute chair, I was at least introduced. But yes, Jessica is here, thankfully, to provide a more in-depth overview, sort of high-level information about where we are on the improvement plan. I do tend to drone on about this, so I'll restrain myself by saying that there are essentially three things that we're doing on the improvement journey. One is addressing the problem with producing EHCPs. That's both doing them on time and doing them well. For that, funding has already been approved and a consultation process has concluded, and people are beginning to be hired to fill those roles to ensure that they're done both on time and done well. Don't have to go back and repeat them and duplicate the work, thereby ourselves. Secondly, we're ensuring that the places that we need for that are funded by the high need funding block in borough, and reducing the number of children that have to go and be educated outside of the borough, further away from their families and away from their community, so that the places that are required are ones that we can fund and build. And that's been addressed, or being addressed, I should say, through the cabinet paper that came recently on capital funding, so that schools in Newham can build their own high needs provision so that we're preparing for the future and the fact that we know that need will grow. And the third thing, which is addressed in this update to Health and Wellbeing Board is co-production. It was acknowledged at the inspection last year that our co-production needed significant improvement. For that, we are hiring a co-production lead to oversee and quality assure. And of course, if EHCPs are properly co-produced with young person, the family, the school, the health sector, we know that it has a far better chance of success. So in a nutshell, those are the three things that we're doing. And I will hand over to Jessica to talk about the improvement in delivering EHCPs on time thus far. We're now 6 months into this improvement programme and where we expect to be in the coming weeks and months.
Thanks very much. And I do apologise for not bringing you in early. Sorry, it's a bit error on my part. Jessica.
Thank you very much, and thank you to Councillor Garfield for that kind of open and introduction. A key focus of our performance improvements and of the recent monitoring visit that we received from NHS England and Ofsted was around, Department of Education, I should say, was around the reduction of the assessment backlog and our EHCP performance, with a particular focus on timeliness. We have reduced the number of assessments that have been open for the longest period of time by 79% as of October 22. And we are on track to complete our backlog by March 2023. A key factor in kind of meeting the demands and sort of addressing the backlog has been the high demand that we've experienced for EHCPs, which has been higher in Newham than in many other boroughs. However, in spite of the pressures, we continue to improve, and our performance on the statutory 20-week assessments that we are obliged to deliver has improved significantly from 0% in April to 34% in October, and in fact was 75% in November. I'll take the paper as read, and I want to leave ample time for questions. But I should say that whilst our timeliness is improving significantly, it is expected that our timeliness will be under the national average. When that data is published, and that is because the metric used by the Department of Education to calculate timeliness takes into consideration the timeliness for all education, health and care plans issued. So the work on the backlog will drag down that overall percentage for this year. However, we are really feel positive that we will absolutely hit that target of eradicating the backlog by the end of the financial year.
Thank you very much. And there's good references, and my colleague Councillor Garfield did mention about the co-production. If we've got a backlog in education healthcare plans, it is genuinely, it's got to involve health partners. And in 320, with the Health Inequalities Funding Board, service level agreement being co-produced by the Special Educational Needs section within the local authority, and representatives from the leadership team, if we can get that working together. And I noted, sorry, I hope that's all right, I'm coming from the chair, but parents on 327, parents, carers and young people, there's a particular issue that I know we're all tasked in the particular cabinet roles that were represented here in terms of the transitions and post-16. And my colleague Mumtaz, who sends apologies tonight, we're looking at how we can improve that pathway, because that's been another point of transition. And it says in 327 about how parents, carers, and we mustn't forget those, young people are currently being consulted on the training they'd like to see issued to GPs in the borough. And that's a genuine commitment, I think, from all of us, that young people should shape the service, particularly in those transition points. So well done all the officers on work. And Sarah.
Very quick question. I'm assuming it goes without saying that the improvement in our timeliness is coupled with our improvement in quality.
May I take that, Chair?
Yes, indeed. Yes, sorry.
Councillor Ruiz, that's absolutely right. And the written statement of action that resulted from the joint area inspection last December has as its first priority an improvement requirement surrounding both timeliness and quality. We are working hand in glove with our DfE advisor on the quality aspect and have pulled together a multidisciplinary quality improvement board which meets regularly, and we have a further session with the DfE with that multidisciplinary board both in January and then again in February. So we are absolutely committed to improving the quality alongside the timeliness, and a key element of that in Newham is a kind of a gradual transition of bringing our plan writing in-house, and as you can imagine, like so many service areas, also increasing our permanency. So we are investing in training of permanent staff.
Thank you, Jessica.
Mayor?
Thank you for the report, and obviously it's a very welcomed read. I would, however, caution against a couple of things. One, in light of our oversight role as a health and wellbeing board, understanding the written statement of action framework, which is set by government, and it has its own kind of view on length of time and quality, which is not the same as what would be appropriate in terms of length of time and quality for our residents in Newham as a place, given that we know our community and our borough more deeply. And, a definition of quality that may satisfy Ofsted and the CQC and enable the respective agencies to tick off and demonstrate a progress towards WOSA success is fine, but I think we need to be much more granular and interrogative of the actual lived experience improvement that children and parents and families are experiencing, because they can be two very different things.
Yeah.
I mean, I absolutely agree. And I think that one of the reasons I asked about the quality is because we've been in this place before where we had a sudden rush of actually getting a significant number of the EHC plans done, but actually they all had to come back because the quality wasn't there. This is not in our time, this is sort of early 2019. So I think, I think that if we can look, and I don't doubt that we would very quickly hear about the quality from parents if that wasn't happening now.
Yeah.
The Mayor's right, we have a legacy to overcome.
Yeah, and that's within. Can I just put my bit in? We've got a national shortage in terms of educational psychologists, and we're addressing that one. But it's about when we do get the quality of educational psychologist support, often people then move, and we need a stability within that. And we've addressed this in other parts of the council, and we continue to do so. But just on that, multi-agency thing, but to make certain that our work with children and families and co-production is not just engaging those professionals like the EP, but you get the feedback from the various individuals about quality. Joshua, did you want to come and respond to something?
I would love to respond, Chair. Thank you. I don't disagree with any of the points that have been made, and that is why I triangulated our approach to improvement at the beginning. Mayor, I think you had stepped out of the room for this, but quality is a key part of our improvement journey. The EHCPs being completed on time is only one aspect. And the reason why we're focusing so heavily on co-production, that I outlined at the beginning, is because that was where it was identified by those inspectorate bodies that we were significantly failing many children and young people and families. So we know from both my level in the political side, Jessica as head of the service, and then of course Tim as corporate director, that our focus is not simply on getting the plans out and getting them done on time, as Sarah alluded to, may have been done in past iterations before I joined the cabinet. We want to ensure that every single EHCP is done properly before we're looking at its timeliness, because there is no point rushing it, getting it wrong, having it returned and having to do it again. By the time that child has an EHCP which meets their needs, it will have it will have little impact on their experience of education, because their needs will have developed further and their needs will have changed. And that is not something that is efficient for us as a local authority and a statutory provider of these services. And it's not something that is beneficial for our relationship with the health service. So we're coming at quality from a multi-agency framework, and we're building on the learning, and we're listening to parent and carers' feedback, and we're looking at how we implement that in our service improvements. That is why we've got a quality assurance lead that we're hiring for. It is why co-production is at the core of every single EHCP, and it's why we're not simply focusing on them being completed on time as a metric. We've got the metrics whether or not those EHCPs are co-produced, whether or not families through the correct forums are happy. And the CQC and Ofsted are only, under DFE, are only one factor in how we assess the improvement of the service. That's why the Health and Wellbeing Board has the oversight that it does. And we'd be more than happy to bring in good time case studies of how our change of approach has impacted particular children's experience of the service.
If I may, I appreciate the points of clarification, but my commentary was much more broader outside of sort of the points that you've illuminated on. And if it is the case, this is the authoritative body that holds the entirety of the SEND improvement process to account, then who defines the quality that we will judge that by? Because I don't think there's been any conversation with the Health and Wellbeing Board as to how that is shaped. So we can talk about, the importance of co-production with families and what's being put in place as part of a written statement of action response and what's being picked up. That's fine. But in the context of our role as a Health and Wellbeing Board, how can we provide ourselves the collective assurance that we're asking the right questions and actually improvement is in line with what we would expect in this area, if fundamentally the improvements will lead to better outcomes with regards to the health, wellbeing and happiness of our young people and their families?
But the board is a consultee on our SEND strategy, and the SEND strategy has only been delayed because we want to ensure that our permanent director of education, who will be leading Jessica and the whole wider improvement programme, can be involved in that process. And that won't come to cabinet before it comes to Health and Wellbeing Board. That's the part of the oversight of the improvement process. And we can certainly brief or have conversations or look in more detail at what it is the Health and Wellbeing Board wants to look at as metrics for that level of improvement. And as I said, timeliness of EHCPs and commitments of the WOSA is only one aspect of that. And we will be open to providing other metrics or case studies of the like. Jessica, do you want to add anything?
Yeah, I'm going to say, just in terms of that timescale point, should bring Jessica in and come back to Roxana. Jessica, did you hear all of that? Sorry,
Yeah, no, absolutely, I did. And, we are taking as Councillor Garfield has said, we're taking a multidisciplinary approach to quality assurance. We, acknowledge that there is a uniqueness to Newham, and we also acknowledge that there are, benefits to taking soundings from the Department of Education, who have a good panoramic understanding of what has worked elsewhere, which we can kind of critically evaluate in its application to Newham. And we have also been assigned an improvement partner. So we're working with Bedford, who have a good record in improving their performance, who are also able to advise us. So we are taking, as I said, soundings from a range of different sources, and also, service satisfaction feedback from parents and carers, which combined informs our approach to quality assurance with greater oversight within the redesigned structure.
Can I suggest that we just capture as an action that sort of framework that we want to apply as a Health and Wellbeing Board, and how that will be designed with us? Because I appreciate the service area and the health partner involved in this will need to define its own framework with regards to the different cohorts of stakeholders, including parents.
Yeah.
But arguably, and I would suggest that that's different in terms of the role of the Health and Wellbeing Board around the oversight.
Yeah. Just briefly.
Chair, we can bring the quality assurance framework, so the assessment pathway, to the board. We'd have no objections to that, and be happy to take recommendations from the board and health partners online before we proceed.
Yeah, it'll be helpful, I think, because it's getting that part of approach, but where we know things. I mean, there's references in the report about, the shortages I've already mentioned about educational psychologists, but there's also about the role of this board in terms of, making certain that, the GPs that I mentioned, for instance, it's about how we can get proper action points in the spirit of what we've done so far this evening. Is that okay, everybody?
Yes, Chair.
We're agreeing we're at the moment, we're just turning to a recommendation on page 207 of the main bundle that the Health and Wellbeing Board is asked to note the progress made against a written statement of action in the areas of risk and challenge presented with the report, with an action point, obviously, for all of the partners involved that we can keep in the loop, as it were. Yeah, that's a bit vague, but let's make it a bit stronger.
Sorry, can we just capture that maybe a then recommendation?
Yeah, let's put it
with the action point.
Yeah. Did you get that, Pauline?
Yes.
Sorry.
Yes, I did. So quality assurance can come to the board for the board to give recommendations.
In order to do the quality assurance part of it. Yeah. Is that okay, everybody? Yeah. Thanks very much. Aging well strategy. Do we have Claire or Lydia on the call? Yeah, Lydia's here. As if by magic. Right. And Claire. So is it going to be a joint act? Who's going to start?
Yeah, we're going to do a double act. So I'm going to start. So good evening, everybody. Nice to see you. My name's Lydia Drummond, and I'm Assistant Director of Commissioning within the Council's Adults and Health Directorate. And my colleague, Claire Grezek, the Deputy Director of Public Health, and I will be providing the board with an overview of our Ageing Well strategy this evening, which was published and launched in July this year. And as well as that overview, we also have some ideas about how the board can potentially support us with delivery of the strategy as well. So the aim of our Ageing Well strategy is to improve the health and wellbeing of all of our residents aged 50 plus and ultimately reduce health inequalities. It's been co-designed with a very large number of residents, 1,500 plus, as well as a number of our health and voluntary community and faith sector partners. This strategy actually supersedes a number of other strategies that we had. For example, we had a dementia strategy, we had an end of life care strategy, etc., with the aim of creating something that was much more holistic, something that was much wider and looked at the wider determinants of health, and also focused on prevention. The strategy supports the council's corporate plan in terms of priority 1, which is healthy Newham and ageing well, and step 14 of the 50 steps to a healthier Newham, which is supporting residents to age well and maximise the quality of life. And it also aligns with the national NHS Ageing Well programme. The strategy has 5 priority areas, which are information and communication, home, finance, employment and volunteering, community connection and neighbourhood, and planning and preparing for later life. Each one of these action plans have got their own outcome measures. and their own outcomes that we'd be looking at that have a number of I statements that have been co-designed with our residents. And we would be looking to update the board on an annual basis as towards our progress towards meeting these outcomes and the different outputs that we have in there, roughly around this time every year, because it kind of coincides with the work that we want to do in October to observe the International Day of Older Persons. So in terms of governance, we have now established an Ageing Well Strategy Delivery Board with 5 working groups sitting underneath it, 1 for each of the action plans. And then supporting those groups, we've also established a resident advisory group, which is open to any resident aged 50 plus to join, and a stakeholder forum for those stakeholders that are interested in basically supporting the delivery of the strategy. 2 residents from our resident advisory group have volunteered to be co-chairs, 1 co-chairing with me on chairing the strategy delivery board and 1 co-chairing with Claire for the resident advisory group. And this is really ensuring that residents are continually involved in the delivery of our action plans throughout the lifetime of the strategy. I'm now going to hand over to Claire, who's going to talk through some of our current focus areas that we're working on as alongside the action plans and which areas the board may help us with in terms of delivery. Claire?
Thanks, Lydia. I am here. Thanks, Lydia. Hi, everybody. So we've looked across our strategy and the priorities, and particularly thinking about the things that residents told us when we engaged with residents. And we picked out 3 areas that we wanted to highlight to the board as areas that we'd really ask and encourage the board to get involved in and play an active role in to support delivering the strategy as a group collaborating on ageing well in Newham. And those 3 areas, and I'll talk a little bit around them, are continuing to engage and involve residents and partners, communicating with older residents in an age-friendly way, and as anchor institutions locally, thinking about how we can support older people, particularly as employers. So on the first one, engagement with residents has been at the centre of developing the strategy from the very beginning, and we committed to that continuing through delivery of the strategy and through developing future priorities year on year. And as Lydia mentioned, we've got our resident advisory group and a stakeholder forum. So firstly, we wanted to make sure everybody in the board is aware of these groups, because they're an amazing resource to come to help consult, engage, inform, and seek feedback from residents and from stakeholders. So really one of the first asks is, please bear them in mind and come along. Everyone is welcome to join the stakeholder forum. It's open to anybody, and anyone who's a Newham resident age 50 is also very welcome to join the resident advisory group. And we'd really encourage people to join and to help us promote these groups. We want to make these groups as big as possible, because that by maximizing access to these groups, we will get the best out of them. And we also want to make them really vibrant, interesting places where residents and stakeholders want to come. So we want to make sure that in our forward plan of what we're bringing to these groups and how we're engaging the people who take part, we're really bringing things that are current, that are important to residents, important to stakeholders, so we can get the best out of the groups and make sure that we're working together to deliver on the big priorities in Newham. So those are the first areas. I'd really encourage you to join and help us promote those groups. The second area is about communication. I know that's come up a few times already this evening. This was one of the biggest areas of feedback we had from residents when we developed the strategy, how residents feel often that they don't know about things that are going on, or they find it difficult to access information. And they really sort of asked for, how can we as organisations communicate with residents and hear from residents in more varied and more accessible ways? So we've made various commitments in the strategy to being diverse in the way that we communicate with residents. So not only doing things online, but always having phone options and in-person options. And that's one thing we wanted to highlight and to say, how can we all, as members of this board, take a similar approach and consider that in our plans. And the second area is slightly broader, and it's about a positive vision of aging. So there's actually evidence to show that if you feel positive about growing older, you live for longer. That's a bit of a summary of it, but that's sort of the headline. So we want to make sure that when we're talking about older people and when we're communicating about issues related to aging, we're doing that in a really positive way, and that we're including older people in things that go beyond issues of older people. So, for example, if we're promoting a new activity in a park, we can include images of older residents engaging in that. It doesn't just have to be children, young people and families and so on. So it's a really big area that we want to work on, and we have lots of ideas and resources that we can provide and support all of the organisations in this group to help to take that forward. And then the final area is being anchors and employers. How can we be age friendly? So in the council, one of the actions that we committed to in the strategy is to do a survey of residents to understand issues that older residents face and how, as an employer, we might be more age friendly. And again, we can provide information and resources to support other organisations in this group do similar things and think about how can we be more age friendly, particularly thinking about those groups that may be disadvantaged in other ways. So thinking of this as an equity issue as well, and really bringing that equity focus to employment. So I'm going to stop there, and Lydia and I can take any questions.
Thanks very much, both Lydia and Claire. Any questions from in the room or online? Questions or observations at this point? Yeah.
Observations.
Yeah.
It might lead to a question.
That's fine.
Really interested in the issue about communication, because when you talk about having a phone or an in-person option, how do people know that there are those options? Because the only time I ever see this advertised is online. So I see it online, and that may tell me that I can phone or in person, but remember, I've only seen it online.
Yeah.
I think also we need to, so I think it's interesting that I presume everybody in this room knows that aging well is it 50 plus?
Yeah.
Yeah. Whereas actually a lot of people think that older people or aging well starts at 65.
Yeah.
And if we look at, I keep on about these coffee mornings in our neighbourhood centres, but they are the least active group that I've ever seen, because they come in, they sit, they drink tea, they eat cake, and they go. All right?
There's exercise there in the coming and going.
In the coming and the going. But it's always the same people, and I would guess that they're all probably, if I'm really honest, they're probably all over 70. Because actually the 50-year-olds are probably still at work, and we don't appear to be able to do anything that all these things happen during the day when people are at work. And I would just like us to think about, you know, anything that's happening in our borough that's nice or involving always happens during the day. And actually we miss out a whole swathe of people who are working.
Yeah.
And I know things happen in the evening as well, but yeah.
And we've got changing work patterns. We've got, you know, since the pandemic, people working from home or, you know, doing sort of more portfolio careers and all of that sort of idea. We've got more ability to reach a group that starts having some health issues if it's not just about watching their weight, and we've got the weight management issue with type 2 diabetes or cardiovascular related to non-exercise. And I like the idea that I think both the mayor and I saw in the parks during some of the launch events that people were genuinely, you know, it was nice weather, obviously, we had to delay it, but it was too hot on one occasion, but you know, the one we did in Central Park, I think Lydia was there, and I know the mayor and I were there. You get good feedback because people feel valued. And if we don't have that messaging in terms of not just our employment, but our communications thing, I think people, especially in the post-pandemic world, can get quite isolated.
I was absolutely delighted on Saturday when I went to Custom House Library that there's a young woman who has got funding through the community assemblies to do some sort of health and fitness thing. It isn't Keep Fit, and it appears like chair-based as well, but the women, and it was only women, were all over 50, but under 70, and that has never happened in that library before. So that was really encouraging. But I don't know how they knew it was going on, because I didn't know it was going on.
Yeah, well, just on that, I mean, I found out that was going on as part of Overview and Scrutiny SIL report last night. Yeah. And I think we do need to communicate internally as well, Lydia and Claire.
Yeah.
I know pressure
Can I comment on that, please, Chair? So 100%, Councillor Rose, you're 100% right. So Claire and I are currently working with the new Assistant Chief Exec of Comms and Marketing to actually better find out where our population are going. So some of the problems that we had when we were promoting some of our launch events is that we did, I suppose, the usual. They went in the libraries and they went to the GPs and to the pharmacists and all of that kind of stuff. But actually, a lot of our population, like working age, are at work, but also that's not really where people are going on a regular basis. They're going to supermarkets and they're going to coffee shops and they're going to the pub, they're going to like different places. And so what we're doing at the moment is we have, through the business rates team, we've identified all the supermarkets, the cafes and other areas within the borough where we're actually contacting them to let them know about our strategy, to see how open they are to working in partnership with us. So will they put up leaflets? Will they have posters? Will they hold events? Will they sponsor items and give us some money? All of that kind of thing, so that we're actually better able to promote that it's not just online and it's not just kind of stereotyping that older people go to their GP all the time and you know, that type of stuff, so that we can reach more people. And then something else that we'll be doing in the new year is we're putting together a bit of a survey, to which we had a really good response the last time we did it, to find out a little bit more from our residents about what exactly is the communication they want, what information are they looking for, where are they going, where can we find them, so that we're able to tailor it even further moving forward. Because although our community festival and our launch events had a lot of people there, the community festival had about 150 people there, and everybody who went enjoyed it and we had positive feedback, it's not enough considering the wider population that we've got. And we're also taking into account now the feedback that we've got, like you've just given, to say that people want evening and weekends, they want to be able to go where we can, like we don't have the parking restrictions, for example, on the weekends. They want to go out into the park, they want to not play bingo, not do knitting, not kind of sing songs to Vera Lynn, etc., etc.
Nothing wrong with that, Lydia.
So it's a wider offer than that currently.
But we are actively working on it, but it is a work in progress.
Yeah, and I understand that.
Yeah, I've got Roxanne. Is there anybody online as well? Probably because
they've all gone home.
Yeah, Roxanne.
Thank you very much. I mean, just picking up on the broad point that Councillor Sarah Roos made, I think similarly, with the questions that I posed to Ajay earlier, how do we also ensure that this approach around our ageing well strategy and what we curate, in addition to being reflective of, you know, the different times and lifestyles that our population sort of have, but also the range, you know, we've had the ONS output around language, and I just kind of feel that we're quite limited in our repertoire of what it is that we design. And you know, where's the innovation or the creativity in co-producing and understanding deeply, actually, in different cultural contexts, the types and ranges of sport or physical activity that would work?
Good challenge. Lydia or Claire on that one from the mayor?
Do you want me to
So
start?
shall I start and then you finish?
Yeah, go for it. Yeah.
So the first thing is that we're collecting the protected characteristics, all 9 of them, of the residents that sign up to be part of the residents advisory group, and who also partake in the different sessions and things that we're holding, so that we're able to see how representative we're being in getting that feedback. And so we're also able to target particular groups kind of moving forward in the years as the strategy go on. We're also beginning to produce, with the feedback from our residents, a number of different formats of doing things. So just recently, we've done a planning ahead video with our partner Subco in all the South Asian languages that have also got BSL signed, and takes into account some of the cultural understandings or needs in relation to end-of-life care planning, for example. So we are beginning to shape what we're doing. We're also doing some work with our LGBTQ plus community in that space, and with the Chinese Association, producing documentation in Mandarin or other languages. Yeah. Claire, do you want to?
Yeah, no, and I think the only thing I would add is to say that we will be refreshing our action plans every year. Yes. And at the very beginning, what we set out to do was to create a really holistic prevention strategy that covered the big areas that are really relevant to healthy aging. But what that now provides is a really good foundation for us to do kind of deeper, more in-depth kind of deep dives and actions for specific population groups or for specific issues. So, for example, we have a big section in there about sport and physical activity. And what we can do in coming years is to really focus on some of those smaller population groups that we know are the least active, and think what are the more bespoke actions that we can take, building on the learning that we've got from the initial phase of the work. So that's all I wanted to add.
Yeah, thanks very much. And I think the challenge from the mayor is that, you know, we do need to make certain that the Health and Wellbeing Board has the action point, and that refresh that will be annually put in there, Claire, as you say, but that we actually do not just the dissemination of information to residents through the various bodies that are represented here, but also those people who we need to engage with on a regular basis to shape a more dynamic offer that is both inclusive and make certain that it's not just the same people who sometimes go, whether it's in Plasto Library or to Councillor Rivers' library in Custom House. Not that we're decrying that, it's about expanding on that sort of, you know, inclusive approach where they feel comfortable, but also I think what the mayor was alluding to is, you know, that we actually have a wider range and a imaginative approach. By something like that, yeah? Sorry, I'm trying to
prolong the conversation on this at all.
Not doing so.
So I will be very brief. And it involves the Newham magazine or whatever it's called.
Yeah.
All right. Because always in the back of that, and I know it's been changes, there was a what's on 2 or 3 pages. We don't have that anymore. And there's probably a reason for it. But that was a lot of our residents would look at the information in there. And I don't know how we do it again, but, you know, so for example, I know how Hibiscus are doing a series of 12 dance sessions with, Sadler's Wells or something. But I only know that because I know it. Yeah, you know what I'm saying? It's
that information.
Where do we get that information from?
And what is good about the activities that are currently running? I mean, I put on Twitter that, you know, the tea dance is full at Stratford, you know, Town Hall. I think that offer, we need to keep advertising the variety so that people are aware. Sorry, the mayor had a response.
I was just going to say, part of the challenge is that you've got a Newham mag schedule that's vastly reduced from the monthly that we had, which makes timely information more easier to present, because you're looking literally at needing to have that information for once in advance.
Oh, right, okay.
And that's quite hard to in the context of 3 pages, but it is something that we're actively looking into as part of the transition of the newer mag. It's just going through a transition.
Yeah, no, I
agree with you. It's valuable.
And I think Lydia did indicate that they're working across the one council approach in terms of getting the communications right, because people don't know, and if we'd have the same offer all the time, how are they meant to know and all of that? But we're asked at this point, colleagues, to agree the recommendations.
Sorry,
Sorry, Jason. I did ask before, but are you just coming in at lastminute.com there?
No, but it's fine. So the only point I want to add, which is really, on top of agreeing about the richness and the diversity of our offer, is that there's much, much more that happens in our community that's not provided by us. And a huge opportunity for us is to try and make all of that as visible as possible. And the work we're doing through the Joy, the social prescribing work that we're doing is all about how we make all of that much more visible and enable the people to get to the things which meet their passions and interests and needs, whoever they're provided by.
Absolutely agree.
Very good. Yeah, very good. Thanks very much for that. So, colleagues, can we agree the recommendations as listed on page 222?
Agreed.
Now, I understand that we don't have officer presence. Is that right, Jason, for the domestic abuse strategy?
We're gonna, we don't, not for today.
Yeah, it is quite a busy time. That was only launched and we're in the 16-day programme. So was that all right, colleagues? We're deferring that item and sitting patiently in the wings, as they say, is
that item.
Laura, thank you very much. To introduce the suicide prevention strategy and action plan. Laura, over to you. Item 7, everybody, sorry.
Thank you, and thank you all for your patience in waiting for us to present our new suicide prevention strategy for Newham. So I'm going to introduce the strategy and I'm going to pass on to 2 colleagues too who've just joined the call, Helen Kay, who's the Children and Young Persons Strategic Commissioning Lead, and Ed Lander from the East London Foundation Trust, who leads on crisis support, because this is very much a shared strategy across partners. So I'm going to give an overview of how we've sort of brought the strategy together, so rather than focusing on the content. So it covers the national priority areas for reducing suicide prevention, which is very important because it helps align our work with what other boroughs are doing and how other people are sort of framing, and in these are evidence-based priority areas. What the consultation period has informed are the 40 actions that underpin it, and that's through interviews with a working group, an audit, which I'll summarise some key points of, and around over sort of different internal and external partners that are summarised on the slides pack. The local authority public health team has a role to coordinate the strategy, but it is very much delivery across a shared wide of organisations, from transport providers, employers, schools, voluntary sector and health and care. And as with anything, we want it to have impact. We don't want it to have high priority actions that don't then lead to delivered action. And actually some people on this call who I've talked to through the development of it have really helped think about how do we make it impactful. So the sort of the 3 key points around that how is 1, so it has got quite a detailed action plan, which sort of sets out what we think we'll try and seek out to do in the first 12 months. And that's to really make sure that we're really thinking about what we can do in partnership. And we also then have that accountability to be able to come back here in a year's time and say, this is what we've done, this is what we've learned. We might not be able to achieve everything, but we'll at least be able to sort of have a clear reference about what our intentions were and where we're going on that journey. And it also gives that clear direction to people in other areas of the system. So if you're working in the East London Foundation Trust, but you're not on the working group or on the subgroups, you have a clear sense about what that direction of travel looks like. The other key bit is that really clear connections with other strategies and aligned programme areas. So it does align with our domestic abuse strategy, our learning disability action plan. It's got some key links around some of our corporate plan and priority areas around things like wraparound support for families in temporary accommodation, we're really wanting to make sure that this is works as well as possible with all the other priorities people are taking forward through aligned strategies. And I'm also part of a North East London borough group, which is looking at where we share commissioned service areas. So, for example, we all share talking therapies and how do we use them to best effect, and we share certain at-risk population groups. So like gypsies and travellers, we know that there are heightened risk around suicide. How do we learn with Havering and Redbridge and other boroughs where we know that are also got population groups that are small in number, but collectively they are very meaningful and vulnerable. And the last bit, I'll just say that we've had this opportunity of a new strategy to really think about how the governance works. And it's a similar thread to the other strategies, but we're co-chairing the working group between myself and Edward Lander. We've got 4 subgroups that one led around children and young people, one around bereavement, one around crisis support, and one around reducing access to the means of suicide. And that just allows us to reach a much wider group of partners without having to bring everyone into the main working group board. And it sort of seems to make sense as a distributed leadership model. My last points were around what the 3-year audit sort of told us, which in some ways, because of not very good granular data, doesn't tell us as much as I think we'd want to know for Newham. So we do know that Newham, compared to nationally, our suicide rate is lower than the national rate. It's lower than the London, but not significantly so. So we're looking at quite low numbers on a 3-year trend of the time period we compared. We're looking at about 18 a year. That's obviously 18 too many, but it is quite small numbers, so it makes those really comparisons quite tricky. We have a higher risk for men than nationally. So nationally, it's about 3 times compared to women. In Newham, it's 4 times. And the age of that risk is younger. So in the national data, it's sort of between 40, 45. In Newham, it's 30 to 35. Women at a national picture are showing an increasing trend of around self-harm and suicidal risk. And the numbers are younger, at around 25 to 29. So these are all important things to carry forward in our strategy. Ethnicity data is incredibly poorly captured, and that's owing to how coroners capture data, and it is an issue being picked up at a national level. When we look at data at a North East London level, there seems to be a relationship around Eastern European men who are at higher risk, and there seems to be some correlation around labourers and Eastern European country of origin, which is something that is known and seen in other types of evidence. But there's a lot we need to learn. And I think my last point before I pass on to my colleagues is that when we look at the numbers of suicide, these are extreme cases of feeling very vulnerable and at a loss. And then there is a lot of suffering and mental health suffering below that, around attempted suicides, around self-harm. And again, this is some of the work of the strategy and the action plan, and looking at some of that data too, because we know that we need to reach out. This is about strengthening mental health support across the population groups, particularly where we know there's greater vulnerability. So if I pass on to Helen.
Yeah, very much for that introduction, Laura. Helen?
Hi, thank you. So the strategy sets out a number of clear priorities and actions to reduce suicide and self-harm amongst children and young people. We've set up a children and young people working group that comprises of sort of practitioners and representatives of young people from across the system. And our sort of priorities include carrying out further work to understand the prevalence of self-harm amongst children and young people in Newham, to understand better which groups are most at risk, how self-harm is perceived and responded to, and where there are gaps in support, how we might be able to address these. And one of the things that we're really aware of through talking to sort of schools across the system really is that they're seeing increasing rates of self-harm, particularly amongst primary age children. And we really want to understand what's the sort of the growing need. So we want to unpick both the data, so the data coming into multi-agency safeguarding hub, coming from CAMS, the data coming from A&E, and then we want to carry out some survey work with schools and with young people to really get underneath what do we know about self-harm, which groups of children and young people are most at risk, and how can we with the young people begin to drive forward work around addressing some of the gaps. We're also sort of taking forward work. One of the priorities, and a number of priorities, is around working with schools and other settings to deliver comprehensive training and information about suicide and self-harm. So people are saying to us, we don't know where to go for help and support. We don't know where to go for advice. Schools are saying we really would welcome some sort of, comprehensive guidance on what we should be doing, both for children who have got ongoing self-harm issues. What can we do? Where can we go for advice and help? So we want to link that to wider programmes of work about mental health awareness, around anti-bullying, and work to support vulnerable pupils. So what will the strategy do? Well, it will enable us to galvanise support from across the system. It will enable us to bring together what people are already doing and support better working together to really begin to address some of the key gaps around information, training and support. So there is some really great work going on across Newham. What the strategy will enable us to do is to bring that together in a more coherent way. So we've already begun the work. We're bringing together colleagues with responsibility for mental health and training in schools, and we're planning a self-harm and suicide awareness week in line with the Children's Mental Health Week in February. So this will provide an opportunity to highlight the issue of self-harm within the wider context of work around children's mental health and suicide and self-harm awareness work more generally. It'll enable us to sort of really promote work with schools. So we'll be delivering a range of seminars and training events and hopefully pull together some good practice guidance for school. I'll stop there and hand over to my colleagues to continue.
Yes, thanks very much. Can we just pause at that point? Is that okay, colleague? There's just an observation, whatever we think of, the soap operas, the EastEnders storyline is doing self-harm, and there's an overrepresentation, I found out only last week at a parliamentary delegation, of people with bipolar disorder who are highly represented in this particular, ending their lives with suicide because of possibly the lack of recognition of their condition, what it means to them, and isolation. And my last point is that, there is nationally a greater preponderance of men to women, but there's also some clear high-risk groups in terms of the LGBT young males and these sections of the community where I think the COVID thing, which you've referred to, the pandemic, page 258 refers to the groups that identified high mental health impacts. So if we're doing suicide prevention work, it does mean that we've got really targeted groups. Like the East European dimension, I don't think even colleagues, need grasp that one. When I say colleagues, I mean within the whole system, as it were. I think there's new dimensions, Laura. That's just as an observation. Yeah. Sorry, the mayor. Sorry.
I wanted to just ask. Well, firstly, thank you so much for this really valuable piece of work, and it makes really sobering and dark reading. And I appreciate that this is a strategy and an approach that will cover a 3-year period. My question is more around the sort of cultural shift that we want to be seeing in a systematic way as part of our wider ambition, whereby at some point in a generation's time, Newham is materially a healthy, happy place where we can point to metrics and features of well-being. So whilst you're focusing on the priority groups, what's being done currently to begin that, or to commence with that journey or progress with that journey? So I'm particularly thinking around the priority areas of action going forward on big page number 252. And you've got the various things that will prioritise over the course of the 3-year strategy, and the actions in point 1 specifically. I understand why those have been prioritised because it's reacting to reality here and now, but what currently is being done to embed that systemic change we want to see, so that our engagement with that cohort of young people from early years, primary school, secondary school, from this point in over the next 3 years can begin to anchor a more healthier, happy, well-being borough in terms of its people in a generation's time?
I'm happy to start answering that, but I might also hand over to Helen, because I feel some of this comes down to the work we're doing around social prescribing and children, young people and mental health in the borough. Do you want to
come in? Because I guess we've been thinking about doing a lot of work around sort of implementing what's called an I Thrive approach to promoting mental health in Newham, and thinking really hard about the sort of the thriving centre. So the work that's going on across Newham to promote emotional wellbeing, resilience for all children and young people, and how we can sort of work with all of our partners to be really driving that forward. And then I guess thinking then about, and how do children and young people access advice and support for those children for whom that is absolutely sufficient. And then how are we really beginning to sort of enable access to support within the community, so that children aren't, if they're experiencing any sort of difficulties, it's not let's just go straight to CAMHS, but actually how can we begin to empower our communities to be working with children and young people. And one of the things that we're hearing is that there's an absolute diversity of provision in Newham, but it's how do people know what's there, and how do they signpost it, and how do people get access to that. So I think that what we're trying to do in terms of our sort of emotional wellbeing and mental health work is that we've been mapping everything that's out there. We've been mapping both the sort of the thriving centre, trying to think about children and young people's needs, and then working with our colleagues to think about how we can devise a system that is bringing more support upstream, so that is doing exactly what you're saying, which is creating really thriving communities, and working with children and young people and parents to help drive that, whilst also being mindful of how we can ensure that those children and young people who are requiring pathways into support, that those pathways are integrated, that they're meeting children and young people's needs, that they're not having to repeat their stories multiple times, and that we've got sort of joined up approaches to addressing need as early as possible within the system, so that we really are working with early years providers, that we're working with schools, we're working with our youth and community partners, and we're skilling people up to be working in a sort of really proactive way, promoting resilience and ensuring that children are accessing, that we're really sort of pulling together the range of provision that's out there in Newham. And we'll be sort of holding ourselves to account on that, really, as to how we're doing. So I hope that.
Did I see Jason indicating? Yeah.
Yeah, I mean, to briefly build exactly on what Helen said, that I think that is about situating this within the much broader approach within the 50 steps, from early years, the work in our children's centres and family hubs, the healthy schools programme, the building resilience, all of those kind of public health approaches leading to the right, for those who need it, then the right support at the right time. So yeah, really just building on what Helen was saying.
And just in terms of, I mean, I should be at a school governing body this evening. The governing bodies that I'm on, we've actually had very good discussions, actually led by, governors, actually saying, in the context of the stresses that the school students were under, as well as staff during the pandemic, a real focus on a discussion. And I think, yes, they've got a strategic role within this. It's about supporting the messages around the whole offer for schools, because it's quite worrying what you were saying, Helen, the figures on self-harm at an increasingly young age. And I think we have to acknowledge that's a reality. Yeah. It's a really difficult
and
time.
there are particular groups of children and young people who we know are most at risk. So we know that children who are on the spectrum are, because of high levels of anxiety, are particularly at risk of self-harm. We know that LGBTQ young people are at risk of self-harm. We know that there are particular groups, but we also know that there are some sort of really positive things that schools and community providers and others can be doing to be working really proactively with those children and young people, to be building esteem, to be sort of supporting anti-bullying strategies, to be enabling children and young people to access positive things to do. So as Jason was saying, sort of a real public health approach to ensuring that children and young people are as resilient and healthy and happy as they possibly can be, whilst addressing the fact that for some children and young people, they will need access to additional support. And how can we make that as simple and as accessible as possible?
Thanks very much. Laura, you had another.
I'm conscious. I know that that Ed Lander also wants.
Sorry, yes.
Yeah, I'll let Ed speak first. I know that wants to speak from the East London Foundation Trust perspective.
Yeah, sorry, Ed, you've been very patient.
Oh no, that's great. Thanks, Laura. Thanks, Chair. I mean, just to speak to your point, Chair, about the elevated risk of bipolar disorder patients and those with sort of severe mental illness, there is within the strategy a focus on those service users who are discharged from mental health inpatient unit and the sort of risky period post-discharge, where there's quite a significant evidence they're at elevated risk of suicide. And again, we had some feedback from our sort of co-production groups around some concerns about the level of support that service union residents were receiving in that period. So that's an area of focus to really ensure that we get that right. Just from a adult perspective, I think the issue of really prioritising those high-risk groups in our community, which Laura sort of described there, and I think a real strength of the strategy is the creation of the subgroups, which I think provides a real structure to ensure that the actions for the priorities are delivered. As mentioned, I'm involved in the crisis training and support group, really focusing upon developing awareness and access to support services in Newham, and we've really been able to achieve a breadth of input from our voluntary sector partners and the statutory agencies to really ensure there's broad representation, so we can really sort of get to grips with some of the upstream risk factors and really emphasise preventative work. And I think really ensuring that we can offer a real breadth of support services to residents who may not be attracted to sort of more conventional NHS or local authority services, but we really try and provide as broader offer and really get that out there. So I think the strategy really does provide a sort of strong and robust framework and governance structure for us to achieve that.
Thanks very much. Just a couple of observations from me again, if that's all right, everybody. That there's reference here to the good work that I know Transport for London have done on this. And, you know, speaking of somebody who was in the education sector, you know, Docklands Light Railway had quite a big workshop with young people on this about safety, but also about, you know, how this is an issue. And for them, and I think it's an impressive document. I'm with the mayor on this. It's how do we make certain that we've got our preventative strategies in place. Nora's highlighted that the numbers are relatively low, but that shouldn't make us complacent, particularly in the context of a cost of living crisis. And I know that other arms of public health, we've been on a national platform on about gambling awareness, and people are sadly taking their lives because of gambling debt and financial worries. And it's something that I think we do need to, you know, make certain that our strategies are all in line. Sarah, did you have anything to add? No, you were.
No, I've in this, so.
Yeah. And thanks for the consultation that you've had. You got anybody else?
Someone's got a
Veronica.
Oh, Veronica. Yes, very patiently. Thank you, Veronica.
No worries. Thank you. Just a quick comment from me, and I'm understanding that this comment might have been made before, but given the ethnic makeup of Newham, there would be added importance in thinking about the intersectionality of these young people. So young people who might be living at home and might not feel free enough to come out to their parents if they're on the LGBT spectrum. Younger people who self-harm and hide it in the context of being a borough that is predominantly ethnic. Sorry, can't even speak today. Predominantly part of the global majority. So just keeping that in context of any future programs that are planned, and just a real understanding, particularly when working with younger people. In our experience, the younger people of this generation are incredibly proactive, particularly about identity politics. And I do think it will be remiss if that is not considered in anything that is planned as well.
Laura, would you just...
Yes, that is That is considered here. We've been talking to some of the youth workers in the council, particularly about the issue around LGBTQ plus safe spaces around conversations and mental health support. I'd like to say that this is a strategy. It is quite broad. There's lots of actions because that's the sort of nature of thinking about all the different levels of risk, but it does interface with the other work that we're part of in the public health team. So there's a great piece of research happening that I know a few of you are aware of through UCL called CALO, which is very much really looking at adolescents' mental health. It's recruiting peers, researchers from Newham's young people community, and it's picking up on some of the threads that we've had this evening around things like language and communication. And in some ways, young people are developing some language skills around mental health from schools, but then they're going back to their homes, and there's an issue there because the parent generation hasn't had that. And I didn't at my school have the same kind of emotional education that my kids are getting. So I think we're going to be learning more and more. We need to make sure that we keep an eye on where there's high levels of risk and we get the right signs and the important thing, the zero suicide prevention training, which is only 20 minutes and it's very impactful, is the three things around: see the signs, say, do not feel afraid to say, are you feeling suicidal, and know where to go for support. But there's something about the saying any conversation around mental health can help break down some of that shame and stigma if it's done in a person-centered, strength-based way. And the more we can understand how to have those conversations across all of Newham's communities and make that feel safe and reduce any sense of shame, then I think that would be one of the really great pathways that we can go down through this work.
Thank you very much. And just from me, on the list on pages 276 to 277 shows a wide variety of partners who we should involve in this very important work about suicide prevention. I mean, a working group that consists of everybody from our public health team, but also the health partners represented on the call, particularly from Elfton, thanks for their contributions for this work, but also, as I said, people in the Metropolitan Police, Aston Mansfield are there, Mind, Newham, Health Watch, and universities, to inform the future approach. So thanks very much. Very good piece of work, but, with the caveats that we'll come back, to this board with further alliterations and policy development progress.
Thank you, Laura.
So is that approved? Is that we accept the recommendations?
And then say, no, we're not approving.
So the recommendation, we're approving the strategy and we're action plan for publication, and we support the partnership delivery, the very points that I think Roxana and the rest of us are making, that, it's about delivery of strategy, actively supporting the launch, going to ongoing, continuing suicide prevention communication campaigns, and commissioning and obviously integration opportunities against priority areas. So there's a lot of work for us to carry on doing. Yeah, thanks very much.
Thank you.
And I think that concludes the...
That's it.
Next meeting.
Oh, right. Do we have a date of next meeting, Paul?
February.
It's the 1st of February. Right. Is everybody clear? It's the 1st of February. And
subject to change. No.
Subject to change, but hopefully we'll be all right with that. I declare meeting closed. Thanks very much. So everybody's contribution.
Yeah.